Hello, good afternoon, everyone. My name is Janice Emmanuel McLean, and I serve as the president of APC Community Services. And it's my task this afternoon to welcome you to the Caribbean Health Summit. This Caribbean Health Summit is a collaboration between APC Community Services, One Brooklyn Health Systems, New York Presbyterian Weill Cornell Medical Center, and the National Association of University Women. We have been doing these Caribbean Health Summits since 2010. And you may ask the question why. We recognize that we had been noticing some disparities or inequities in the Caribbean American communities. And so we launched out on this very important summit back then. I can hardly believe it's 16 years since we have been doing this. Now, it's important for us to understand why this conference. I just said because we noticed the disparities or the inequities. Today, we are going to focus on a number of areas. The areas that we have chosen to focus on, cardiovascular diseases, and this is because this is the leading cause of death. And did you know that it is estimated that 697,000 people annually are affected with this disease? And 30% of that number is actually from the Caribbean American population. So this is something of great concern. When we think of prostate cancer and colon cancer, two other areas that we will be focusing on, in 2026, it's estimated that 283,300 men will be diagnosed with prostate cancer, and about 34,700 will die. And when we look at the statistic a little closer, we notice that it's the most common cancer affecting Caribbean Americans. Colon cancer is the third leading cause of cancer deaths. And in the Caribbean population, we notice there is a steady increase, and it supersedes that of the other ethnic groups. When we look at suicide, the statistic is saying that every 11 minutes in the US, someone dies because of suicide. And in the Caribbean region, and even among Caribbean Americans, we have noticed an increase. And then finally, the last area we will cover, domestic violence. 24 persons, we are told, every minute are victims of physical violence. And I can go on and on. But all the presenters today will give you a bigger picture. I'm just giving you a snapshot. So again, on behalf of APC Community Services and our collaborating partners, I say welcome to 2026 Caribbean Health Summit. I'll now turn it over to Sharon Lead, who would introduce our keynote speaker.
Thank you so much, Ms. Janice. I would like to introduce someone who many people know and some do not, and that I have the pleasure of introducing Dr. Sandra Scott, who serves as the CEO for One Brooklyn Health System, which oversees the Brookdale campus, Interfaith campus, and Kingsbrook Jewish Medical Centers. She brings years of experience in the healthcare leadership and emergency medicine. Before Dr. Scott stepped into the CEO role, she has made history as the first woman and African-American executive director of Brookdale Hospital. She earned her medical degree from Baylor College of Medicine, completed her undergrad studies at Louisiana State University, and trained in emergency medicine at Boston Medical Center. She has held leadership positions at Rutgers, New Jersey Medical School and Lincoln Medical Center. Since joining One Brooklyn Health in 2018, Dr. Scott has focused on expanding access to care, improving patient outcomes, and strengthening hospital operations for communities in the East and Central Brooklyn. Ladies and gentlemen, I would like to introduce you to Dr. Sandra Scott, the CEO for One Brooklyn Health.
All right. Well, thank you so much for that wonderful introduction. And thank you, Ms. McLean, for creating this forum for us to discuss some very important chronic conditions in our communities that are impacting life expectancy, and they're avoidable. A lot of the conditions we're talking about are avoidable and or treatable. All right, so we'll go on to the next slide. Okay, so the first thing I wanted to do was to kind of level set what we're talking about when we speak about health inequities. Health inequities are avoidable differences in health outcomes. And these are not due to our biological factors or our genetics. These are, in fact, due to the conditions in which we live. So, for example, there are social drivers, poverty, poor health literacy, housing. So the lack of housing impacts your health outcomes and your ability to combat health conditions. There are some systemic barriers. So lack of health insurance is one that's really at the top of discussion in the media and a top concern for me as a healthcare leader. We know that with the One Big Beautiful Bill, many people are losing their health insurance. And when people do not have health insurance, it creates a huge barrier to accessing primary care, to getting their medications, and therefore worsening health outcomes. There are social and cultural barriers. Language barriers often prevent people from seeking healthcare. The amount of anxiety that a person has when they know they may enter a healthcare facility and not be able to adequately communicate their concerns or their symptoms actually prevents people from seeking care. And Sharon mentioned that I'm an emergency physician, and I can tell you I saw this play out every single day, right? Someone who is struggling to explain their abdominal pain. You know that doctors ask a myriad of questions. When did it start? What does it feel like? What causes it? And if you have a difficulty translating your symptoms to the physician, it can actually impact our ability to interpret the seriousness of your condition, to interpret the appropriate diagnostic test, etc. I think that there's also just the stigma that surrounds some of the care that we provide in the hospital and medical setting. We'll go to the next slide, please. So we mentioned cardiovascular disease, and you heard just a few minutes ago that this remains the #1 cause of death. I know that we have a breakout session and a further discussion from our division chief of cardiology, Dr. Chatto, and he'll go into this a little bit more. The rate of the death rate due to cardiovascular disease is 40% higher amongst Black Americans as compared to white Americans. When you look at the ability for diagnosis and treatment, there are also barriers there. So when people have cardiovascular conditions, we know that often they're offered less aggressive care. So an example would be a common procedure would be to perform something called a diagnostic cardiac catheterization. So if your doctor suspects that you have cardiovascular disease, one of the things we can do is a procedure to actually look at the vessels within your heart that feeds your heart, right? So we know that our blood vessels feed our brain and our abdomen and our muscles. Our heart actually pumps blood to itself. When those vessels are compromised, then in spite of your heart being the muscle that's providing blood to the rest of your body, your heart's ability to supply blood to itself is compromised. So that diagnostic cardiac catheterization allows the physician to see if the vessels that are feeding the heart are actually compromised. That's a common procedure. And when we have positive findings with that procedure, there are other things that we can do that are that can actually open up those vessels. There are medications that we can provide that allow the heart to actually achieve the appropriate blood supply. That has to be recommended by a physician, and then the patient actually has to have the means and the access to have that procedure performed. In terms of preventive medications, things like treating high cholesterol, right? If the individual is able to access the treatments for high cholesterol in a timely fashion, prevent progression of disease, you can actually prevent a cardiac death. So those are some of the underdiagnosed and undertreated challenges that we have with cardiovascular disease. And last but not least is living conditions. I think one of the ones that is really top of mind for me is our diet and having access to good quality food, healthy food, whole foods. So that means that a whole food, a healthy food, means that the nutrition that your body is extracting from the food you eat allows you to have better metabolic performance, right? So eating a good wholesome salad, right, versus a bag of potato chips will actually give your body a lot more nutrients and an advantage to be able to function better. We'll go to the next slide. So we mentioned prostate cancer earlier. I think the graph on your right, sorry, it's on my left, hopefully it's on your right, demonstrates the heavy burden that African American men face with prostate cancer, right? A 2 times higher death rate for Black men. Now, it turns out that historically, we talked about the digital prostate exam, and I was watching a streaming channel just a few days ago, and it was a comedy show, and the very opening scene in that show was a man who, they were making a comedy skit out of a man receiving a digital prostate exam. That is actually not the primary recommended mode of screening for prostate cancer today. We know that a lot of communities and men have a resistance to digital prostate exams, and that can actually be something that prevents them from seeking care. It turns out we have a blood test. We have we call it the PSA. There's a prostate screening assessment that can be done. It's recommended that we start doing that screening between the ages of 40 and 45. And I find it really interesting that that's not promoted. So that's something that we need to talk about. It's a blood test, right? It's a blood test like a blood sugar test. It's not any more invasive than a lot of other blood tests that you would receive when you go to see a physician. And it can detect very early signs of prostate cancer and save a life. When we talk about the stigma to screening, one of the things I thought about is that young boys don't even know they have a prostate. Young girls often learn about their uterus and their ovaries very early, and it's part of health discussions with young girls. We should do the same for young boys and young men. They should know what their prostate is, what's the purpose of the prostate, and the fact that they need to keep their prostate healthy. They need to do cancer screenings. And I think if we include that type of health education at an early age, it will empower our young men to be a lot more comfortable and a lot more knowledgeable about their prostate and the fact that they will need to do prostate cancer screening when they get older. Next slide. We mentioned colorectal cancer. 68% of colorectal cancer deaths are preventable with timely screening. It is the #2 leading cause of cancer death in the United States. And we heard some beautiful statistics earlier that dive a little bit deeper into how the Caribbean, American and Caribbean population is impacted by colorectal cancer. Screening, again, saves lives. It allows us to intervene earlier in the disease state, which decreases the cost of care, and it improves health outcomes. One of the things I think that is under discussed when it comes to colorectal cancer screening, a lot of us think about colonoscopies. We know that access to colonoscopies is a bit of a challenge. That is a procedure that's typically performed by a specialist, a gastroenterologist. In some circumstances, surgeons perform this procedure. Getting access to a gastroenterologist can be quite challenging. It's a specialty that's in high demand. However, we now have home test kits. And some of you may have heard of companies like Shield and Cologuard, but you can see your primary care provider. They can have this home test kit sent to your home via mail. And in the privacy of your own home and the privacy of your own bathroom, you can collect stool samples, mail those back to the company. They will perform tests on your stool, send the results to you and your provider so that you can have a conversation about your risk for colorectal cancer and whether, the test detected some concerns that would require further testing. It's really easy. It takes literally maybe 15 minutes to perform that test yourself. It takes away some of the fear and stigma around colorectal cancer screening. I think that's something we absolutely should talk more about as a community, as primary providers. Those of you that are in the healthcare industry, that's a test that makes screening for colorectal cancer much more accessible and much easier. I think also the important knowledge that younger adults are not immune to colorectal cancer. And one of the most devastating things is to see a young person that is struggling with dealing with end-stage colorectal cancer. So I think that giving the knowledge about the symptoms of colorectal cancer, so when someone sees blood in their stool and they're 25 years old, they have the health knowledge to know that, yes, it could be hemorrhoids, but it also could be the early signs of colorectal cancer screening. It's important to have a conversation with your provider about your risk and further screening to ensure that you're safe. Next slide. And then we mentioned suicide and mental health. There's a rising incidence of suicide across the African American community. And I really wanted to highlight that this month is Pride Month, right? And we know, in particular, youth that are in the gay community, the LGBTQ and plus community, have a higher incidence of suicide attempts, completed suicide. So this is a popular, and particularly if they're Black and African American. So, in honor of Pride Month, I just really wanted to make sure that I call that out. There's a shortage of culturally competent care when it comes to suicide and mental health. 4% of the psychologists in the United States are Black or people of color, and about 6% are Hispanic. We do know that when it comes to mental health services, that oftentimes when there's a cultural connection, when there's cultural competent, cultural aware care, that patients are much more at ease with discussing some of the challenges that they have with their mental health or even just the symptoms of their mental health. So it's really important that we overcome the barriers of talking about mental health in our communities. And I think one of the beautiful things that I see in the education system is that youth are starting to learn about their emotions, and not just the emotions of being angry and frustrated, but all of the other emotions, so that if young people have a vocabulary to talk about how they're feeling, right, when they're in distress, it makes it it much easier for them to identify for themselves and then feel comfortable to describe to others when they're suffering from depression and anxiety and shame. So we'll go to the next slide. Domestic violence and intimate partner violence. In the emergency department, about 20% of women who seek care in the emergency department are victims of domestic violence, and about 10% of men. However, I do believe that that number is underreported. I find that in general, it's difficult to get the full story when someone presents for healthcare, to be able to connect their symptoms to domestic violence. It really requires educated clinicians to be able to tease that out, right? When you identify an injury or condition that's just not consistent with the story that you're being told, to have at the top of your mind, could this be an abuse situation, right? So if the clinicians, the nurses, and the doctors and the social workers do not have this at the top of mind, oftentimes patients will not automatically tell you the true circumstance around which they experience their injuries and their psychological complaints sometimes. I think one of the ways that we can help as a community to improve awareness is to educate ourselves about domestic violence, to educate ourselves about the symptoms, and don't be afraid to open the conversation with your friends and your family and your neighbors, right? If you see something, you hear something, you suspect something, be comfortable to ask about safety in the home. And I find it's good to just come straight out and ask, are you safe in your relationship, or are you experiencing abuse from your partner? And once you open the door and you're comfortable having those conversations, oftentimes those who are suffering from abuse are a lot more comfortable having the conversation with you. We know that poverty actually amplifies the risk of domestic violence. However, domestic violence crosses all socioeconomic conditions. And I'm actually on the board of an organization that specifically focuses its efforts on women and men who are not impoverished, because a lot of times there's even more shame disclosing that they're victims of domestic violence. So while poverty increases the risk, every socioeconomic class is actually at risk for domestic violence and experiences domestic violence. We know that pregnancy also increases the risk of domestic violence. So if you know that, which if you didn't know it before, you know it today, something to keep in mind and something to be comfortable with engaging in a conversation. If you know someone who's pregnant and they seem depressed, stressed, or you see signs of injury, have the conversation. Most survivors actually never report their abuse, and I think it has a lot to do with shame and stigma. We also know that financial dependence traps survivors. So people who want to get out of their situations, but they can't envision a way for them to be able to take care of their children and provide housing for themselves. So they stay in an unsafe situation. And most women in the United States of America that are killed by an intimate partner. And that's a statistic that's often not discussed. And we'll go to the next slide. So common thread to health and equity are all of the things that you see on the screen, and some of which I've discussed. Social isolation, healthcare access gaps, poverty, economic distress, racism and discrimination, trauma, stigma, and silence. So these are all drivers of health and equity. And we'll go to the last slide. And I just wanted to kind of highlight what we can do individually, what we can do as a community and what we can do for systemic change, because of most of what I'm talking about is rooted in systemic problems. As individuals, I highly encourage you to, I say, know your numbers, but be cognizant of your blood pressure. We know that hypertension, sometimes people call that the silent killer, but check your blood pressure. In this day and time, you can have your own personal blood pressure machine. You can get them for about $20. You can order them online. They're actually in most drugstores now. Get that check your own blood pressure. Make sure you're doing your regular wellness visits, so that you can have a conversation with your provider, with your primary care provider, about your risk for hypertension, about things that you can do to mitigate hypertension. Cholesterol, I think, is another, hypercholesterolemia, I think, is another silent killer. Sometimes people have symptoms that make them, think about their blood pressure. High cholesterol, you're not likely to have symptoms that you're going to connect to high cholesterol. So for your cholesterol and your blood sugar, that annual wellness visit will help to keep you informed about your own health conditions. And obviously, we talked about cancer screening. We don't have breast cancer on here, but I think that's another opportunity for us to have a community conversation. Make sure you're getting your own screening and also promoting breast cancer screening within your friends and family. And then check on your loved ones and your friends. I mean, I'm a doctor and a CEO of a health system, but my sister is a gastroenterologist, and my sister checks on me to make sure I'm getting my colon screening and getting my mammograms. And it makes a difference. It really makes a difference. In spite of, being in healthcare, living in the hospital every single day, just having my sister periodically say to me, I think it's time for you to, to get your colon cancer screening. And if you don't do it, I'm going to come and screen you myself. And that motivates me to get my screening. But, when you have the conversations with your friends, family, and neighbors, it actually helps them to remember to check on themselves, and that you love them and that you care about them, and that it kind of creates a sense of accountability to you because they love and care for you. And then we talked about intimate personal violence. So today you'll have an opportunity to learn more about the signs of abuse, right? So that when you feel something's not quite right, you'll have a little bit more knowledge about what those signs and symptoms of interpersonal violence are. And the more you talk about intimate personal violence, the more comfortable you come across as someone who's non-judgmental. And when you have that non-judgmental approach to having these conversations, it really opens the door for someone to tell you their true story and to be vulnerable about the abuse that they may be experiencing in their home. As a community, I think one of the things we can do, in addition to wonderful forums like this one today, is in our trusted spaces, have conversations about healthcare. I once heard of a beauty salon where the stylists were actually trained in having healthcare conversations. So we know in our barber shops and beauty salons and churches, there's a lot of networking and conversation going. And I just thought this particular salon went above and beyond to make sure that their stylists actually had training, had psychological training, so they could pick up on signs and symptoms of abuse, depression, and anxiety. So that's a way to, in the community, have safe spaces to talk about some of the conditions and prevention measures that we'll discuss further today. Connecting your neighbors and family to community health centers and crisis resources. A lot of the phone calls I still get from my neighbors and my family is to help them navigate the health system, to help them figure out where should they go to get dermatological services, to get their cancer screenings. So the more knowledgeable we are, the more that we can share that information into the community. And then I think also supporting our youth I'm sure there'll be more discussion today about the struggles of suicide, depression, anxiety amongst the youth. Having those conversations with the youth that you have access to, and not just talking to them about the activities that they're engaged in or the sports that they're engaged in, but actually having a little bit of a deeper conversation about their mental health, about their sleep habits. I think about the youth that are consumed with video games, right? The video games and being at home in your room on a video game all day can promote isolation and other vulnerabilities that go along with gaming. But so if you know a youth that is on the internet and gaming all the time and they're not outside socializing with others, you might enter into a conversation with them. What are some of the challenges that they have? Who are they gaming with, right? Are they gaming with friends that they actually have relationships with outside of the virtual space? And just opening the door and having those deeper conversations can really give people an opportunity to self-reflect and seek the help that they need. On the systemic change side, I talked about Medicaid. One Brooklyn Health is a safety net institution. Most of the patients that we serve are insured by Medicaid. And I've spent the last year thinking about processes that we can put in place, ways we can collaborate with community-based organizations, with insurance plans to make sure that we help everyone who's eligible for Medicaid stay on Medicaid and then be able to manage the additional hurdles that are coming into place because of the HR1, or One Big Beautiful Bill that's creating more and more barriers for people to be able to access health insurance. Your advocacy, right? Your support for those elected officials who understand that we need Medicaid. Medicaid is health insurance that allows people to have access to health care, and making sure that you are aware when you're voting, that you're voting for someone that's going to promote the health and wellness of our community and of our country. One of the things that's been at the forefront of the healthcare industry is actually looking at our health-related outcomes, and looking at marginalized communities and by ethnicity, by gender, by age, to make sure that we're able to identify those cohorts of people that are actually having worse health outcomes, so that we can change the way that we're delivering healthcare, change the way that we're creating access, so those communities that are not that have poor health outcomes, that we're actually focusing our efforts to bring them into care and to help them be safe and healthy. I would say also supporting workforce diversity. Thankfully, One Brooklyn Health has a very diverse workforce. That's not true and many institutions across New York State. The more diverse the workforce is, the more patients will feel comfortable seeing people who look like them within the health force to enter the healthcare workforce. And then voting for policies that address housing, poverty, and food access. And all of these matters have been at the forefront of the federal discussions and the state discussions around policies to ensure that we provide the resources to our communities so that they can access the health and care that they need. So I'm excited for the lineup of speakers that we have today. My intent was to give you a little, to kind of get your brain stimulated, so you have you can ask the deeper dive questions and the breakout sessions with the experts that we have here today. Again, I want to thank you for putting this Health Summit together. I think these conversations are extremely important. It will help to uplift the health literacy of our communities and galvanize us to take care of each other. So thank you very much.
Thank you very much, Dr. Scott, for a very informative keynote. And we're going to get ready now to go into our various breakout groups. all those who registered for cardiovascular disease, you go nowhere, you stay right in the main room, but the others would go into their assigned rooms. At this time, we'll have our host give us some directions on how that will be done.
All right, good afternoon. It's now our time for a breakout room. Once the rooms are open, you're going to see 4 options on your screen: colon cancer, prostate cancer, suicide prevention, and domestic violence. You choose the option that applies to you. If you're on a mobile phone, you might need to scroll on the screen in order to get to the desired room. Once again, if you're here for cardiovascular health, just remain right in the main room and we will get started very shortly. The rooms will open in 5, 4, 3, 2. They're live.
Welcome to this session on cardiovascular disease. Dr. Hal Shador is our speaker, presenter for this session. He is the chairman of cardiology at One Brooklyn Health and professor of clinical medicine at SUNY Downstate Medical Center in Brooklyn, Interfaith Medical Center, and Kingsbrook Jewish Medical Center. He has dedicated much of his time and career to advancing cardiovascular care in underserved urban communities. Under his leadership, he has played a pivotal role in the expansion and modernization of comprehensive programs and new technologies to advance heart health throughout Brooklyn and beyond. Dr. Shador was also instrumental in creating the accredited cardiovascular disease fellowship program at One Brooklyn Health, where medical students, residents, fellows, and junior faculty can be trained and mentored. In addition to his clinical and educational responsibilities, Dr. Shador serves as chair of the Institutional Review Board, promoting ethical clinical research and advancing evidence-based medicine. He is particularly interested in shaping the future of cardiovascular care at One Brooklyn Health and the Brooklyn community at large. Dr. Shador earned his medical degrees and further training from the universities of Guadalajara, New York Medical College, and Long Island Jewish Medical Center, as well as SUNY Downstate Medical Center, and he is a fellow of the American College of Cardiology. We welcome Dr. Shador to this session. I'm sure he has a lot of information and good things to tell you about cardiovascular disease and cardiovascular health. Dr. Shador, the time is yours.
Thank you, Ms. Modeste, for that really kind introduction. Thank you, Dr. McKenzie, and to your entire group for inviting me to speak with you this afternoon. I have been tasked with talking about new and emerging technologies for screening and detection of cardiovascular disease. And I think that the speakers before me did an amazing job of introducing the topic. But the agenda will be the burning platform, the cardiovascular mortality trends and current pitfalls. We'll discuss the global syndemic, including hypertension, obesity, diabetes, and smoking, goals of primary prevention, advanced biomarkers and risk stratification, coronary artery calcium score, and coronary CTA, which is CT angiography imaging, the use of artificial intelligence in cardiovascular screening, which has really taken off over the last few years. And we'll conclude with some remarks about genetic testing. So it's interesting because if you look at overall cardiovascular mortality from 1970 down through the last till about 2022, what you begin to see is that there's a steady decline in overall mortality. Why? Well, in the 1970s, we introduced the concept of coronary care units, which already reduced the incidence of sudden death remarkably. In the 1980s, we introduced clot-busting medicines called thrombolytic therapy. And in the 1990s, we introduced primary angioplasty to treat, which is a procedure to open blocked arteries to treat patients with heart attacks. And that resulted in a significant decline in mortality from about 30% down to about 8%. But what you begin to see is that cancer, which was the leading cause of mortality, cardiovascular disease is now beginning to catch up. It has increased by 18.2% over the last 5 to 6 years, and is now accounts for about 45.5 people per 100,000 in terms of deaths. There's actually 19.4 million deaths from cardiovascular disease in 2021. Of those, 9.1 million were from coronary heart disease. But this is one of the most striking statistics that I've come across, and that is that people in our own backyard who live in the Brownsville section have the highest rate of premature death, higher than any other part of Brooklyn. And a significant part of that is due to cardiovascular disease. Why is that? Well, we know that the traditional risk factors for coronary heart disease are hypertension or high blood pressure, obesity, diabetes, high cholesterol, and smoking. There was a target that was introduced at the federal level to get what we call the 80-80-80 target. What that means is our goal is to have 80% of the people aware of their diagnosis of hypertension, 80% treated, and 80% at target. But now you begin to see why we're falling short. Only 60% of people are aware that they have hypertension, and I think that Dr. Scott alluded to this earlier. Half of them are being treated, but only 1 in 5 has achieved their target blood pressure goals. And the same could be said for some of the others. Well, what are the other problems that we have? As doctors said earlier, we have fragmented specialty care. We have barriers to access, limited service line growth, and limited outreach. Before I go any further, I just want to put some terms out there and define them. When we talk about primary prevention, what we're talking about is a person or an individual who has not had any clinical evidence of coronary heart disease or vascular disease, and we're trying to prevent them from having that event. Whereas secondary prevention are people who have had a heart attack, stroke, or some other form of peripheral vascular disease. And what we're trying now to do is prevent another event or worsening events. Just to give you a timeline overall, so we know that this atherosclerosis or hardening of the arteries actually begins in the first decade of life, where we deposit this little fatty streak. Over time, because of these risk factors, high blood pressure, obesity, smoking, diabetes, what happens is that the lining of the artery, called the endothelium, which is a living, breathing part of the artery, it enables the artery to relax when we're running and doing and need more blood supply, and it contracts a little bit when we're sitting still and need less blood supply. Well, when that barrier is tainted, what ends up happening is these cholesterol particles begin to form in the lining of that wall. And over time, they will grow and grow and grow until we develop symptoms. I just show you this diagram because it's really not so much important how severe the blockage is, but what we've learned over time is that if this is the blockage, this is a thin covering, what we call fibrous cap. These thin fibrous caps may be stable for the moment, but they have a high propensity for rupture in the future and causing heart attacks, strokes, leg problems. But when this fibrous cap, this covering is very thick, then that is stable for the moment, and it has a very low propensity for plaque rupture in the future. So the goal of our therapy is to convert these vulnerable plaques into these very stable, thick plaques. And I like to describe it as a safe. Of course, if we're going to protect our valuables, we much rather have a thicker door protecting our most precious valuables than a thin, flimsy door that can be peeled off without any problem. And just to drive home one last point before moving on, if we do an angiogram today, and as Dr. Scott alluded to, that's a test where we can inject dye to see where the blockages are, and there's a 30% blockage and a 90% blockage. And in 6 months from now, that person goes on to have a heart attack. 2 out of 3 times, it's that 30% blockage that caused the heart attack, not the 90%. Why? Because the 90% is probably a stable plaque with a thick fibrous cap, whereas that 30% is probably a vulnerable plaque with a thin fibrous cap. So what are the goals of primary prevention? Well, this year was an amazing year in cardiology because 4 major guidelines came out, one of them being lowering cholesterol. And there was a complete paradigm shift. The previous guidelines recommended that we start evaluating people early, but not really doing much until they hit the age of 40. What we now learn in the new guidelines is that we are actually now need to start evaluating these people and these children in childhood and move them over. And we also changed the risk score that we used from the what's called atherosclerotic cardiovascular disease risk score to what we call the prevent risk score, which gives us a more robust answer as to patients' risk. So what we do is we enter patient data into this risk profile, and at the end of it, we are given a risk score. It's a 10-year risk score of developing an event. And if your risk is less than 3%, you have a very low risk. If your risk is between 3 and 5%, you're borderline. If your risk is between 5 and 10%, you're intermediate. And if your risk is above 10%, you're very high risk. Anybody with a risk above 3% probably has some way and will benefit from treatment. Getting our blood pressure for most people below 130/80, and if they're diabetic, especially if they have coronary heart disease, getting that blood pressure below 120. Now, patients don't like to take medicines because Dr. Scott said hypertension is called a silent killer because they don't feel symptoms until it's too late. We have so many classes. We have actually a new class just came out, FDA approved this year. We're up to 9 or 10 classes of drugs that we have to control high blood pressure. Yet only 1 in 5 of people in our neighborhood have their blood pressure controlled. And just to, so that we put this into perspective, the average American will require 3.5 medications to have their blood pressure controlled. Some may require 1 or 2, but others may require 4, 5, or 6 medicines. Physical activity is important. Performing 20 to 30 minutes of walking every week, at least 5 times a week. We now only recommend aspirin for patients who have established vascular disease. Its use in primary prevention has failed to show benefit. Type 2 diabetes. It's very interesting that about 10 years ago, there was a drug for diabetes called Actos. And after this drug was FDA approved, it turned out that people who took this drug had a higher incidence of developing heart failure and dying. And the FDA at that point made a significant change. And they said, we're not going to approve any diabetic medication from now on unless they establish cardiovascular disease. And now we have several new classes of drugs called the SGLT2 inhibitors that go by the name of Jardiance or Farxiga, the very famous GLP-1s, the Wegovys or the Mounjaro. that actually are used more for non-diabetic medic indications than they are for diabetic indications. But it is very important that patients get their sugar well under control, and that is a hemoglobin A1C of less than 7. A diet that emphasizes vegetables, fruits, nuts, fish, legumes, and whole grains, and obviously tobacco and even marijuana, even though it is legal, it is really not safe from a cardiovascular perspective. And that doesn't matter whether you're vaping, whether you're inhaling, it is really not good. So basically, the paradigm shift is now screen earlier, check regularly, get it lower, and treat for longer. So what we have done is we have now partnered with our pediatric cardiologists, pediatricians, and adult medicine people, plus cardiology, to develop the Brooklyn Adolescent Transition Program. And the goal of this program is now to take children who are at higher risk of developing cardiovascular disease or who may require treatment for their cardiovascular disease, for their elevated lipids, and now transition them from the pediatric arena into the adult arena rather seamlessly. And this is a program that we are developing as we speak and hope to launch in the near future. But one thing we also realized is that even if we get patients down to their goal, and their goal could be less than 100 if they don't have diabetes, less than 70 if they do have diabetes, less than 55 if they have blockages in their arteries, coronary heart disease, and even the European guidelines and recent data suggest getting the LDL lower than 40. But we still know that there's a significant number of patients who are still at risk in having events. And the question is why? And the answer lies in this advanced biomarker slide. We have come to learn that there are advanced biomarkers that play a significant role in patients with coronary heart disease. So even if you get the LDL down, your apoprotein B, which is really a measure of, it basically measures every single particle capable of building plaque in your arteries. It measures LDL, VLDL, IDL. It's basically, instead of measuring, right, how many, what the mass of the cars are on the road, it's actually telling you how many cars are on the road. And so once the patient has gotten their LDL to goal, we now look at apoprotein B and say, if your apoprotein B is still elevated, then you still need further lowering of your LDL cholesterol. Another area that we found, and this is very exciting because within the next few months, there are going to be drugs available to specifically treat this, and I'm sure you've all heard a lot about this, is called Lp(a) or lipoprotein A. Now, this identifies your genetic risk, so you only need to do this once in your lifetime. So this is essentially an LDL particle that has an extra sticky protein attached to it. And basically, it camouflages it from your liver, allowing the particle into your bloodstream to stay longer, and it is highly atherogenic. Now, while the statins may lower it a little bit, and the newer drugs, PCSK9 inhibitors like Repatha, etc., may lower it a little bit more, there are actually now targeted drugs that are going to be coming out within the next year that will lower your Lp(a) by 80%. The other things, homocysteine, we know that it increases the risk, but we're not able to do anything about it yet. And high sensitivity C-reactive protein, well, there's actually some conflicting studies, but it does appear that for stable patients, the addition of colchicine, which we use to treat gout, in addition to aspirin, may actually lower C-reactive protein and improve outcomes. So our ability to measure and treat these advanced biomarkers is revolutionizing what we do. But is there anything else we can do beyond simple blood tests and risk scores? And over the past several years, coronary artery calcium score and coronary computed tomography angiography have become mainstay things that we can use to evaluate the patient's risk. So let's say I have a patient whose risk is either very low or borderline. But yet they tell me, doc, I have a very strong family history of heart disease. My father had a heart attack at the age of 50. My grandfather had a heart attack at the age of 45. So what we can do is we can measure the coronary artery calcium score. It's a simple test. It's a CAT scan. There's no IV contrast, no P treatment. You don't need any specialized CAT scan for this. It's a simple to interpret score, and it's recommended for asymptomatic patients. But if I have a patient who needs a further evaluation, I can actually assess the coronary arteries non-invasively through this cardiac CTA. I can see if there are blockages. I can assess non-calcific plaque. I can assess cardiac chamber size and the heart muscle. And again, this is recommended for symptomatic patients. So if I have a 0 calcium score, that tells me that that patient is low risk. However, if this patient is in the 100 to 300 range, that is a moderate risk patient that translates into a patient with a risk that would warrant treatment. I could tell you that 3 years ago, personally, one night I ended up in the emergency room, and in the morning I had a coronary CAT scan, a cardiac CTA, and calcium score. Now, thank God I didn't have any blockages, but my calcium score was 126, and now I take a statin every single day, and I have gotten my LDL down. So we are not immune to this as well. And clearly when the risk is above 300, and even when it's above 1,000, those are really high-risk patients that we really want to jump on and lower their risk as much as possible. And this is just some of the images you can see, how clearly we can see the coronary arteries that are bathing the heart in blood. This is the right artery. This is the artery down the front of our heart called the left anterior descending. And this is the artery to the back of our heart called the left circumflex. Well, we all hear about artificial intelligence every single day. And it's actually been around for longer than you think. But its impact on medicine, and especially here at One Brooklyn Health, has been monumental. So let's just define artificial intelligence. Artificial intelligence is processing massive amounts of data using algorithms on large data sets to recognize patterns, make predictions, and support clinical decisions. And broadly, we divide them into 3 broad categories. Generative AI. We can create text, video, audio-based user, things like ChatGPT. What about machine learning? Computers learn from your historical data to improve the accuracy. Netflix, Spotify, YouTube, all of you, I'm sure, use these in your daily life. What about natural language processing? Machines have the ability to read, understand, and interpret human language. Hey Siri, hey Alexa, Google Assistant. What's the key promise here? The key promise is that AI can be used to detect subclinical disease years before the symptoms, enabling earlier detection, cheaper, and more equitable cardiovascular prevention. How is this being applied? Well, it's being applied in electrocardiograms and wearables. People can buy Apple Watches. This is not an Apple Watch, but people have Apple Watches. And as a matter of fact, there was someone in my community whose son was abroad and he was having palpitations. We bought him a watch. We were actually able to diagnose Wolff-Parkinson-White. It's an abnormal heart rhythm. He came back to the United States, underwent a curative procedure, and was cured. Echocardiograms. Cardiologists, can look at what is the heart function? What does the heart muscle look like? Novices use This can be used to assist novices to quickly and accurately assess how the heart is doing. We can use AI in MRI and nuclear CT, as well as coronary angiography. I'm going to show you some examples of each of these. So what about AI-enhanced EKGs? Everybody is familiar with the electrocardiogram. It's been around for several hundred years, but we can detect atrial fibrillation, which increases your risk of stroke. And the sensor with about a 98% sensitivity. What about reduced heart function? Mayo Clinic has an AI algorithm that can detect severely reduced heart function as low as 35%. There are algorithms that can detect electrolyte abnormalities, high potassium, low potassium, all of which can be potentially life-threatening before the patient feels any symptoms. What about age and sex estimation? AI estimates biologic cardiac age from the EKG, and we are embedding EKG screening in routine visits to identify these high-risk patients at One Brooklyn Health. This may seem like back to the future, but ladies and gentlemen, the future is here today. What about AI and echocardiography? Well, deep learning automates our ability to measure the heart function, which is extremely important because it really tells how well the patient will do in the long run. It helps people who may be doing echocardiograms, but may be in their beginning stages, to really make sure that they're getting all the proper views. It can help us assess valvular disease, aortic stenosis where the aortic valve doesn't open, or maybe it's leaking, or maybe the mitral valve is leaking. Point of care echo is being used every day now. Basically a handheld echo. We have one so that we can take it down to the emergency room. We can take it to the floors. We can use it in an emergency, and it enables us to envision the heart without needing an immediate cardiology consultation, because then that can be transmitted to the cardiologist. An AI-enabled echocardiography can support mass screening, critical for the underserved patients like in our community of Brownsville that have sometimes limited access to care. What about AI in cardiac CT and cardiac CT angiography? Well, we get an automated calcium score, which we just discussed, which has a significant impact in identifying patients in whom we would want more intensive lowering of their risk factors. Plaque characterization. Deep learning identifies high-risk plaque features. We can't yet see the fibrous cap because it's very thin, micron small, but there are features within the plaque that will enable us to identify high-risk features, again, to try to stabilize that plaque. Now, let's say we see a blockage on the cardiac CT and we're not sure how significant it is. There's something called fractional flow reserve that enables us to, using AI, to identify whether this lesion is significant. Think about it this way. If you have a wine bottle, if you pour it out through this thin spout at the top, that is the flow through a blockage. But if you were able to cut the bottle right at where it is the fat part, then what ends up happening is that would be the flow normally. And if you could compare that flow, then you will be able to determine, is that a significant lesion that needs cardiac catheterization or not? Normally, up until this, we had to bring the patients into the hospital, do an invasive procedure, put a special wire down the artery, and then take the measurements. We could now do these non-invasively. We can measure pericoronary fat, detect vascular information before the plaque is even visible, and most importantly, we can dose optimize, resulting in about a 50 to 70% reduction in the X-ray. What about AI in cardiac MRI? Well, we can detect scar. We can detect fibrosis. There are certain infiltrative diseases that will result in an increased risk of sudden death. If we can identify those, we could then begin to start more intensively monitoring those patients and try to decrease those risks. AI accelerates mapping for fibrosis, for myocarditis, for amyloid, and for sarcoid. These are infiltrative diseases that we are now beginning to detect with an increased frequency. Why is that important? So this year, in collaboration with the Advanced Heart Failure Group from New York Presbyterian, who are now full-time here at One Brooklyn Health, we have started amyloid programs. So we are now screening select patients for amyloidosis. Why is this important? Because there's now several treatments that exist to treat amyloid and reduce their risk of sudden death and their progression to advanced heart failure. What about accelerated acquisition? We can get a cardiac MRI in under 15 minutes. And we can also do stress cardiac MR, and we can evaluate how well the blood is flowing through the arteries, as well as what's happening to the wall motion during stress, improving our ability to detect multivessel coronary artery disease. Well, what about wearable technology? We have the smart EKG, we have the Apple Watch, the Samsung Watch, and several others that are available. Photoplasmography. Imagine lying in bed and having a camera shining on you, and just by looking at changes in your skin that are invisible to the naked eye, you can detect blood pressure. You can detect abnormal heart rhythms such as atrial fibrillation, and you can detect sleep apnea. Ladies and gentlemen, this is here today and FDA approved. Implantable loop recorders. It's a little device about the size less than $50 that's implanted under the skin. And patients who have abnormal heart rhythms, it can stay there for up to 3 years. And it transmits in real time when these patients have abnormal heart rhythms, alerting us early. Digital biomarkers such as heart rate variability, which is the difference in heart rate from time to time, pulse transit time, changes in respiratory rate. All of these can predict heart failure decompensation before hospitalization and before symptoms developed. What are the equity implications here? Wearable AI must be validated in these diverse populations. The main problem is, and this is one of the reasons why I am so passionate about research, is when we look at major clinical trials, minorities, and women for that matter, are usually underrepresented in these trials. And that is why clinical research at One Brooklyn Health is so important, so that we not only give patients access to these new investigational drugs and devices before they become FDA approved, but we improve your representation in these clinical trials, which is important to us. And believe it or not, it's also important to the pharmaceutical companies. So if we were to compare the traditional versus the AI-enhanced cardiovascular screening, the traditional approach relies on clinical scores. And we know that clinical scores do have their pitfalls. It misses 50% of patients who will have the first myocardial infarction with low risks. And we talked about this residual risk using biomarkers and other tests. Its specialist-dependent interpretation creates access barriers. Binary decisions. You either treat or don't treat, with no shades of gray built in. It's population level, it's not really individualized. So do I know that a clinical trial that was published actually will have the same benefit in East New York? And lastly, it's a single time point assessment, whereas the AI-enhanced approach integrates imaging, genomics, wearables, and these biomarkers into continuous risk markers. It identifies high-risk phenotype patients before the risk factors may even be clinically apparent. And it democratizes expert-level analysis for generalists, where a specialist may not be available. The probability-based nuanced risk communication is improved, precision machine tailored to the individual, and dynamic monitoring with real-time alerts means we don't have to wait several hours, several days, or a week for that result to come back. So what are some of the implementing AI at OBH? One of the first things we implemented many years ago, almost 10 years ago, was something called Viz AI. So when we started our stroke program, and a couple of years later started our pulmonary thrombectomy program, we now have the ability to see CAT scans of the brain and CAT scans of the lung immediately after the technician finishes that study. It comes as an alert to our phones. We're able to see that CAT scan. The stroke neurologists are able to see that CAT scan of the head, and we can act immediately to make sure that we're going to appropriately treat that patient without having a delay in waiting for the radiologist to read. So what happens here is we have screening tools that could extend expert level cardiovascular risk assessment into our community with an underserved population. What about workflow integration? It's seamless. It can flag high-risk patients automatically at the time of routine visits, closing the prevention gap. Algorithm biased. Most of these AI models were predominantly in white males. And our goal is to try to validate these in diverse populations and minorities and women. What about data infrastructure? AI tools require high quality structured data and robust IT infrastructure. We are fortunate to have that here at One Brooklyn Health. Clinical trust. The physicians must understand that the AI does have limitations. It does still require, I know there was a remark, I don't know how true it is, but it was reported that HHC thought that at some point in time they would be able to do away with radiologists because AI would be so good. Now, don't get me wrong, I think there will come a time when AI will have a more significant role in everything that we do, but again, it can't replace the physician into that human interaction. And lastly, FDA-cleared AI tools carry known performance benchmarks. However, we can develop off-label or internally developed uses for these things. And lastly, I want to talk about genetic testing, because genetic testing, we have become to realize over, in the last 20 years, with the completion of the Genome Project, which is a multi-million-dollar project sponsored by the NIH, where every gene was basically sequenced. The question is, how do we get that to our patients? So we now have the ability to a partnership with Invitae to actually do genetic testing. We now do genetic testing for amyloid. We do genetic testing for patients with a unfortunate syndrome of sudden death called Brugada syndrome. We can now do genetic testing to prove patients who we suspect have familial high cholesterols, and then use these results to screen other members of the family as well. Who should consider it? Patients, first-degree relatives with a family history, early prevention, those who want personalized care, and informed decisions. So what do these genetic tests help you to do? Well, they will help you to diagnose. They will pinpoint genetic factors that cause your disease. They will predict how severe your disease might be. It may be able to help choose the best medicine and correct dose. For example, we now know that in certain cancers, genetic testing is used to decide which chemotherapeutic agent is being used. It can help us discover genetic factors that increase your disease risk, find genetic factors that can be passed on to your children, and something that is being even done today is screen newborns for certain treatable conditions. And I would even go one step further. I would say that in some communities, couples that are looking to get married actually undergo genetic testing because of fear that if they marry somebody who has two recessive genetic traits, that might be passed on to their children. What are the pros and cons of genetic testing? Well, clearly early disease detection and prevention is a plus. Personalized treatment and planning is certainly a plus. Informed family planning decisions, improved medication selection and dosing, enhanced screening protocols, And maybe it helps people emotionally and psychologically be prepared for what's coming down the pike. But that could also be a negative. The psychological distress could be debilitating. It could really be an incomplete risk assessment and result in a significant financial burden. We do not charge our patients for these tests. We're doing them at no cost because of this thing that we have with the company. And the false security or undue risk. In other words, if the test comes back falsely positive or falsely negative, and sometimes it's just limited actionable information that comes back on these tests. So in summary, I would say that advanced biomarkers enable earlier, more precise identification of these high-risk patients. A coronary artery calcium score or cardiac CTA are powerful tools for subclinical cardiovascular disease detection. AI-powered imaging analysis is transforming cardiovascular disease and screening accuracy. And these technologies are available at OBH, and we hope to expand them as we move forward. And this is working to close the gap in fragmented care, limited outreach, and delayed diagnosis. Thank you.
Thank you very much, Dr. Shador, for this excellent, informative presentation. We are now going to open the floor for questions. You would need to unmute your mic, ask your question, and then you can mute again. Thank you.
Doctor,
Yes.
tell me the LDL again. The
When you
LDL, the
tell
bad
me
one?
the LDL again, what do you?
Is that the bad
Yeah,
cholesterol?
so LDL is the bad cholesterol, and it is measured on a routine blood test. And then based on your age and other risk factors, your blood pressure, the presence of renal disease, if any, your body mass index, how if are you overweight, are you obese, are you ideal? It then puts together a risk score called the Prevent Risk Score. You can do this, yourselves online. You can look it up, Google the Prevent Risk Score, enter the data, and it will give you a score. If that score is less than 3%, that is ideal. If it's between 3 and 5%, meaning that it's a 3 to 5% chance of having a atherosclerotic cardiovascular event over the next 10 years, then that's borderline. 5 to 10% is intermediate, and more than 10% is high.
Okay. So when they do the routine test, they give the percentage?
No, so they give you the numbers, and then it is you and your physician to ask what is the score. So whenever I have a patient, I am sitting with my patient and calculating that score based on those factors, and then I have a discussion with my patients. And based on that discussion, we will either start with what we call risk factor modification, start with diet and exercise plan. I'll give them a heart healthy diet that they can follow and see how they do over the next 3 months. If I repeat it in the next 3 months and they haven't made much progress, then we have to talk about the next step, which is starting medical therapy, usually with a statin. Now, if they already have established vascular disease, then that is a patient that we would start on therapy right away. And those are the patients we really want to get their LDL down to prevent a secondary event.
Okay. So it's important for me to ask my doctor what that number means.
Correct.
Okay. Okay. That's helpful. Thank you.
Doctor, I have a question.
Yes, ma'am.
The question is, can AI detect the exact artery that is involved in edema?
In what?
Edema, the swelling of the legs.
So we're talking two different things. The arteries supply the heart muscle. Arteries basically bathe all of our organs, all of our muscles. They bring oxygen, they bring nutrients to our muscles. We can use the EKG to start with, but the EKG is very crude. And unless something is actively going on, we're not going to be able to tell what artery is involved. In order to begin that process, for some patients, we may do a stress test with imaging. And depending on what wall is problematic, we'll be able to take a very educated guess as to which arteries or arteries may be blocked. Okay? And then we would go to the next step, which would either be a coronary CTA or an invasive angiogram. Edema has multiple causes, swelling of the legs. For some patients, it could be because of venous insufficiency, meaning that the veins which carry blood back to the heart and have these little gates along the way to help keep pushing up the vessel are not competent, so they swell. Certain medications, like calcium channel blockers, like nifedipine or amlodipine, may cause swelling of the legs, and certain heart conditions may cause swelling of the legs. So while swelling of the legs may be a manifestation of heart disease, it is not always a manifestation of heart disease.
Hey, thank you.
You're welcome.
Do we have any more questions?
I have one more question. So
Yes.
how do you lower the LDL again?
So the first line therapies that we use are called statins. And the two statins that we use mostly are atorvastatin, which goes by the name of Lipitor, or rosuvastatin, which goes by the name of Crestor. Then the second line drug is called Zetia or ezetimibe. Now, if the patient, for whatever reason, is unable or what we call statin intolerant, maybe they took a statin, but they had muscle problems or some other problems that they can't take it, there's now a newer drug called Nexlizet, which has also been shown to lower cholesterol. If those first-line medications don't work, then we go to the second line. And these go by the names of PCSK9 inhibitors. These are usually injectable medications that are either given every 14 days, or there's one called Leqvio, which is given 0, 3 months, and 6 months. And there, what's nice about that one is we give it in our infusion center. You come in, you get the infusion, it's a quick shot, and you go home. And you don't have to worry about it for the next 6 months. You come in twice a year. So these drugs are called PCSK9 inhibitors. And if the patient doesn't reach their goal with the first line therapy, we then go into using those drugs. Specifically, Lp(a), there are 3 drugs that are currently in clinical trials. One of them recently got FDA approved, and the hope is that it will be commercially available in the first quarter of 2027. Those drugs reduce Lp(a) levels by up to 80%.
Okay. But if the patient, this is their first time having a high LDL, you would instantly put them on medication, or would you advise them to
So it
try
depends
something
what
else?
their score is. If their score is, again, we call this shared decision making, right?
Okay. Okay.
We have 11, 12 full-time cardiologists at One Brooklyn Health. A host of others who are voluntary.
Okay.
We sit in front of a patient. I tell patients, we become partners in your healthcare. It's not that I'm telling you what to do. I'm explaining that you have a certain risk based on what's going on in your life, based on your blood pressure, your weight, your kidney function, everything else.
Okay.
If your risk is low, then I would start with diet and exercise. If your risk is even borderline, I might start with diet and exercise and see how you do. But once your risk is already in the intermediate and high risk, at that point, diet and exercise are unlikely to give you the changes that you're looking for, and unlikely to lower your risk without statins. And you have to understand, I'll use the medical terminology, and then I'll explain it. Medications have what we call pleiotropic effects. What is a pleiotropic effect? It means I'm giving you the cholesterol-lowering drug to lower your cholesterol. But there are so many other benefits of these drugs that we can't even measure. We know, we talked about that lining of the called the endothelium of the arteries. It actually repairs the endothelium. It serves as an antioxidant and improves the flow. Now, we can't measure those routinely, but we know very well from studies that that is actually happening. And so that it's beyond the numbers, because what happens is that when we measure cholesterol, especially secondary prevention for patients who already have established disease, that the mortality is much lower than we would have predicted than the numbers of the LDL themselves.
Okay.
And by the way, the same is true for the Mounjaro and the Wegovy drugs in weight loss. When these drugs have been studied for peripheral vascular disease, overall cardiovascular disease mortality, heart failure, we're actually beginning to see the benefits long before the weight loss actually fits in. So clearly there's a benefit to the weight loss, but we know there is, we don't understand it fully yet, how the mechanism, but there clearly is a benefit of these medications in reducing the risk of cardiovascular disease.
Thank you.
Thank you so much. I think I'm getting a little notation that we need to. I see something flash across my screen. But there's one question I would like to ask, though. You mentioned about a heart-healthy diet that you share with patients. Is this individualized?
It's not individualized because, well, let me rephrase that. Well, the type of diet that we're providing patients depends on what else is going on. So, for example, if I have a patient with high cholesterol and they're diabetic, they're going to get both diets. They're going to get the high cholesterol diet, and they're going to get a diabetic diet. If I have a patient with high blood pressure, I know that there are certain groups of patients who have what we call salt-sensitive hypertension, meaning that they are more sensitive to the effects of high blood pressure from salt than others. Those include older patients, those include African Americans, and those include women. So my discussion will be different and individualized, but at the end of the day, a heart-healthy diet really looks more or less the same for most individuals.
Thank you so much. I understand that the time has expired, so we have come to a close of this session. We really appreciate your work, and we appreciate you being with us and speaking to us today. Thank you.
So much.
Oh, you're welcome.
Today we have as our presenter, Dr. Dominique Thomas-Vazon. He is the program coordinator for New York Presbyterian Weill Cornell Medicine. And he serves currently as the Community Outreach Management Officer. He has many years of experience in public health, especially in cancer and community outreach, as well as research and engagement. Currently, he manages 2 teams of community peer health educators specializing in prostate and lung cancer. And they have been able to do a lot of work in the neighborhoods as it relates to screening for not only colon cancer, but also lung cancer. So I am delighted to present to you Dr. Dominique.
Thank you so much for that wonderful introduction, Janice. It's my pleasure to be here. Just a small caveat. I'm actually here because my colleague, Dr. Jialin Mao, couldn't make it, so I'm here to present her material. So just as the small caveat, I'm happy to answer any questions that I can regarding her slides, but if there's anything more in depth, I can certainly that I cannot answer, I can certainly write the question down and get in touch with her directly for you guys. But why don't we go ahead and get started? And since we're a small group, please feel free to go ahead and unmute yourself and treat this more like a conversation instead of just me talking at you. But if you'd rather just listen, that's also fine too. So we're here today just to talk a little bit more in depth about colon and rectal health. Dr. Scott did an amazing job of mentioning and giving some of us the background on this problem and this topic. But we're going to go a little bit more in depth, especially around the different choices that folks have around the screening tests for colon cancer. So just to start, if you hear the term colon cancer, colon and rectal cancer, colorectal cancer, large bowel cancer, or large intestine, cancer of the large intestine, they're all talking about the same group of diseases that affect this part of our digestive tract, known colloquially as the large intestine, otherwise called the colon. So the colon is the last large piece of your digestive tract. Connects to the small intestine here. This is the eventually ends in the rectum and anus. The colon is largely responsible for absorption of water, vitamins, and some other nutrients, and notably creating the waste products that we eventually expel through the rectum. Yep. So what does the large intestine do? Largely absorbs water and electrolytes and processes our food waste. So you heard a lot about some of the issues that we can have with our colon, but if we have a healthy colon, how can we keep it that way? Well, first thing to do is to make sure you are staying well hydrated. Water really is an amazing resource for us. It helps prevent not only colon issues, but all sorts of other things. Keeps you energized. Important when you're exercising. Super important to stay hydrated and keep drinking water. Can you drink too much water? Yes, you can, but most people are usually on the more dehydrated side. If it starts feeling uncomfortable, then definitely slow down drinking water. Welcome, Alice. I see you joined in the middle. All right. So another way we can keep our large intestine healthy is by eating more fiber. So things like grains, including oats like an oatmeal, whole wheat pasta, legumes, which include lentils and kidney beans, all different kinds of vegetables, and many different kinds of fruit are all really great for being sources of fiber and also just keeping our digestive system as well as the rest of our body healthy. A lot of people ask, really detailed questions about, which vegetables are the best, which fruits should I concentrate on? My answer is always the ones that you'll eat, right? I think one of the issues that we see in the community today is lack of access or kind of homogenous plates of food that people have. When really, what we like to see on a plate of food, just in general, is, a nice big helping of vegetables and or fruits, along with the grains and legumes, and importantly, variety of foods, right? So a good rule of thumb when you're kind of deciding, what to have for breakfast, lunch, and dinner is if your food looks kind of like these pictures and has a lot of different colors, you see a lot of greens, yellows, reds, browns of the grains. If it looks like a rainbow, it's probably a good place to start with the food. These colors come from different compounds within food called polyphenols, and a lot of them have a lot of wonderful properties. And a good way to make sure that you're getting the benefit of all these different resources is just trying to eat a large variety of different colors of food. other way to keep our large intestine healthy is to stay active. So by this we mean going to the gym, going on walks, going jogging, even dancing, staying active. And just like drinking water, just like eating all those healthy fruits and vegetables and fiber, staying active not only helps the health of our large intestine and the rest of our digestive tract, but really the entire body. So maybe the best news about all these preventative measures that you can do to try to keep your colon healthy is that that benefits the rest of your body too. All right, so before we get a little bit more in depth about cancer screening, I would like to revisit this idea of risk factors for colon cancer. So the general recommendation is that people start screening for colon cancer at age 45. That can change a little bit depending on your personal situation, such as other chronic issues that you might suffer from, any specific issues with your digestive system that you suffer from, or especially your family history of colon cancer. If you had someone in your family who got colon cancer at an age younger than 45, that may be a reason for you to start screening earlier. So if you have the knowledge of this about your family's history of colon cancer and there is someone with it, it's definitely something to bring up to your primary care doctor and make sure that you're doing everything kind of as needed to make sure you're screening at an appropriate age. And if you don't know your family history, it's definitely worth asking your family members if you can, and figuring out your family history of not just colon cancer, but all sorts of different chronic diseases can really inform the way that your healthcare providers can keep track of and test and keep an eye on all these different chronic diseases that may run in your family as your healthcare journey throughout life goes on. But bringing things back to colorectal cancer screening, Dr. Scott did mention that there are alternatives to the colonoscopy. As we'll see in the next slide, the colonoscopy is really the best way to screen for colon cancer, and we'll get into why in just a bit. But I did want to talk about these stool tests. So just you can raise your hand in the chat if you like, or you can unmute yourself and say, has anyone ever had a colonoscopy before? And if you don't feel like answering, that's okay too. All right, well,
I have.
Oh, excellent. I'm glad to hear it. And as I'm sure you experienced, and maybe the others have heard offhand, the day you get a colonoscopy is not a fun day. We'll admit that right up front. The day before, they have you drink this liquid that can really cause some discomfort. It's supposed to clear your bowel out. The day of the test, they give you anesthesia, so you're not awake during the colonoscopy. And they do ask you with every colonoscopy to have someone take you home because of the lingering effects of the anesthesia when you wake up. It's not super safe for you to drive yourself home, so they ask you to have someone kind of bring you home to make sure you get home safe. And all this adds up to, like I said, not a very fun day. But the good news is with colonoscopy is that if they take a look at your colon and everything looks good, then the pain of that one day basically means that you don't need to come back again for 10 years. So that's the advantage of the real advantage of the colonoscopy is that if it's clear, they won't ask you to come back for a decade, right? Whereas with these tests that you can use at home, they're in the cases for their use case is basically people who are at normal risk for colon cancer, not elevated risk. So this means you don't have anything going on with your digestive system at the moment. You don't have a family history of colon cancer, and your doctor may ask you a couple more questions about diseases that can affect your chances of getting colon cancer. But if you're just, someone with no family history of colon cancer, no history of digestive problems, and you're at, the age of 45 or between the ages of 45 and 75, you may be a good candidate for these take-home stool tests. So as Dr. Scott mentioned, the way these work is you take this kit home that comes in a little envelope. You take a sample of your stool and then you drop it in the mailbox, you mail it in, then the results will come through your doctor's office or through your patient portal. The great thing about this is you don't have to go through the colonoscopy at this point, right? It's an alternative that's admittedly less painful and less uncomfortable than a colonoscopy, but it does have its downsides as well. So the first thing that we should note is that if these take-home stool tests come back as abnormal, they come back and flag something as having to be checked out, the next step is a colonoscopy anyway, right? So a lot of people think, if I'm gonna get these take-home stool tests and have to do a colonoscopy anyway, might as well just do the colonoscopy. The other downside is, in contrast to the colonoscopy, where if you are clear and in your colonoscopy, you don't have to come back for 10 years for these stool tests. You typically have to repeat them every year, and for different kinds, every 1 to 3 years, but still more often than a colonoscopy. Any questions about these take-home stool tests? So, move on. Okay, so just a little bit about the colonoscopy itself. We talked about it already in the previous slide, but just so you know how it works, basically with colonoscopy, after you're put to sleep, a camera that is on this wire that will be guided by the doctor is inserted through the rectum, and then it literally looks through around your colon to check for anything unusual. So they're usually looking for little growths that can indicate early colon cancer. If they do find something, one of the nice things about colonoscopy is if they find something they'd like to, get a sample of or even remove, they can do that, very easily, sometimes on the same day. If they do find something that they need that requires follow-up, say a small growth, they may ask you to come back sooner than 10 years, just to check that this growth has not progressed in a startling way. But by and large, the colonoscopy, again, is repeated once every 10 years, starting at age 45. If you haven't gotten your colonoscopy and you're above the age of 45, it's not too late. You can definitely, start a little bit later than that. And if you didn't start at age 45, the next best time to do so is right now. Let's see. Any questions about the colonoscopy? And these other tests here, the flexible sigmoidoscopy, which looks at the final part of the colon, the sigmoid, or this CT machine, which they use to take pictures of the inside of the colon, are also used sometimes. But these are often used either in conjunction with or as a alternative in special cases for the colonoscopy. Again, as you can see with the star, that's the it's considered the gold standard for screening for colon cancer, colonoscopy. So if you are able to get one, that is what we recommend, unless there's a good reason, for you not to get one. So, is colorectal cancer screening, including colonoscopy, including these Cologuard kits, covered by insurance? Yes, yes, it is. For most people. So if you're on Medicare, private insurance, or Medicaid, these insurances do cover all types of colon cancer screening. If you or someone you know does not have health insurance, New York is actually a wonderful place to be for that, since we have something called the New York State Department of Health Cancer Services Program, or CSP. They are a program that operates throughout New York State that offers people, regardless of insurance status, so with or without insurance, the opportunity to get these cancer screenings, including colon cancer screening, as well as other types of screening, including breast, cervical, breast and cervical cancer screening. They also offer, really great information on the website about cancer and other types of disease. So encourage you to check them out. Again, if you have not yet gotten a colonoscopy and you are uninsured, or you're not sure about your insurance status, I would recommend giving them a call, and they're more than likely able to help. All right. So, one thing that we should mention about these screening tests, including the colonoscopy, including the prostate-specific antigen screening test that Dr. Scott mentioned, including the lung cancer screening test that was briefly mentioned, and breast cancer screening test, which is the mammogram. One of the most important features of these tests is that they can catch cancers at the earliest stages while they are small, kind of localized and easiest to treat, before they spread and become larger issues and much harder to treat. So what that means is these screening tests, including colonoscopy, can catch things like colon cancer when they're just starting, even before they start to cause symptoms in the person. So what you see on the screen now are symptoms of colon cancer, as well as, digestive issues at large. So you could have abdominal pain, stomach pain that doesn't go away. Maybe you'll see blood in the stool. If there's a change in your bowel movements or habits, like, you're going way more often, or you can't go as often as you normally do, or, there's a change in the consistency of the stool, like a lot of diarrhea or something like that. These are all signs that you should go see a doctor as soon as possible. So there are, times when you do need to go to the doctor for something urgent. Colon cancer screening, by contrast, is something that if there's one good thing about it, it's that it's typically a slow-growing disease. So that's why, if your colonoscopy is clear, they don't ask you to come back for 10 years, because, science says that if they don't see anything that first time, then 10 years later is a decent amount of time to wait before checking to make sure that everything's okay again. But again, the takeaway with this is that if you have any of these symptoms and they're not going away, please go see a doctor as soon as possible. And on the flip side, even when you're feeling perfectly healthy, please keep up with your regular doctor's visits and things like the colonoscopy and your cancer screening tests. They're super, super important, even when you're feeling perfectly healthy. Because like we said, these tests are designed so that they catch things, before they start causing major issues. So I'd like to take this time just to mention a study that's being conducted by my colleague, Dr. Jialin Mao, who unfortunately wasn't able to be here to give this presentation. So I'm here presenting her slides in her place. But the purpose of her study is to hear about the experiences of folks who are getting cancer care, and to better understand the challenges that people who are getting treated for cancer, often from underserved communities, face. The goal of the study is to identify opportunities to improve access to cancer care for people who typically are underserved. So who's eligible to participate in the study? Folks from underserved communities and have received surgery with or without other treatments for either colorectal cancer, pancreatic cancer, esophageal cancer, or stomach cancer. Or providers who have patients that have this condition. So the study is, just answering questions in a 30 to 45-minute interview. And if you do participate, you will receive a $50 gift card after the interview. So again, if you know anyone who has had surgery for colon cancer, pancreatic cancer, esophageal cancer, or stomach cancer, they may be eligible for this study. Right, so again, it's just a short 30 to 45-minute interview for that study. If you yourself are not, don't fall under this criteria, but someone you know does, you can feel free to give them this contact information here, and we will get in touch with them as soon as we can. All right, before we continue on that, any other questions about colon cancer screening, colon health in general, the study?
What is the duration of the study?
The duration, as it's still ongoing. I'm not sure when, how much longer they'll be keeping it open, but I do know they're still actively accruing patients. So,
okay.
But I can definitely check with Dr. Mao for a more detailed answer.
Quick question.
Sure.
Do you have to be in New York to be a part of the study, or it does not matter where you're located?
Oh, that's a good question. Do you have someone that you would maybe like to refer?
Yes.
Okay. So what I would do is, so this is Dr. Mao's email right here.
Okay,
And
let me
this is
just,
the,
I'm going to screenshot it.
Absolutely, yeah. And this is the phone number to contact them. So, yeah, I think, they're mostly recruiting patients from New York, but I haven't heard anything to the contrary about folks coming from outside the state. So definitely worth asking.
Okay.
Okay. So I also just wanted to add a little bit about my department, which is the Cancer Center's Office of Community Outreach and Engagement, and just talk a little bit, very briefly, about the different programs offered through our office and how to take advantage of them. So we offer various workshops, very much like this one and the workshop given by Dr. Scott, that go through the ins and outs of different types of cancer modalities. So we have the BRAVE program, which is led by Claudia Duarte here, which is a workshop about breast and gynecological cancer. It's fantastic. My team provides prostate cancer screening and education through the PC Peer program. We also offer free prostate specific antigen screening through our office. We have the Be Well for Life program, which is a lifestyle and wellness program led by Muriel Pereira, pictured here. And then just in general, we provide all different types of health education and patient navigation depending on the needs of the community. So if there's a health topic that you're thinking of that you wanted to get a speaker for, and it's not on this list, you can definitely still reach out to us, and we'll try to find someone within our network that can give that talk. Similarly with patient navigation, even if you have someone that's looking for referrals, say for primary care and not necessarily cancer, that's also something that we can assist with. One other program that we launched this year is our lung screening van. So this van contains a full CT unit that can be used to conduct lung cancer screening. And the lung cancer screening is specific for people with a long history of heavy smoking of cigarettes specifically. So the criteria for the screening are down here. The screening is typically covered by insurance if you match each of these three criteria. It can be a little bit more complicated than the criteria for colon cancer screening or breast or prostate. So if you are unsure, if you meet these criteria, you can reach out to this number here or fill out the survey on this website. And someone will from our team will get in contact with you and kind of talk through the details of this screening. If you're interested in having the lung screening van come to your community event or organization, they are still taking dates for a little bit later this summer, although they require about 4 to 8 week lead time for arranging all of the different permits, promoting the event, and identifying individuals within your organization or community that are at risk that can take advantage of the lung screening van. Educational workshops are also provided through this program, both in preparation for the van coming to the organization, but also just as a general informational session. So if anyone is interested in that type of workshop around lung cancer screening and lung health, that's also something that we offer. All right, so thank you so much for having us and for listening to the presentation. If you have any questions about anything that I mentioned, please feel free to call or email us at the contact numbers listed on your screen. Thank you so much.
Okay. Do we have any questions for Dr. Dominic? Edward, do you have a question? Are you in the prostate cancer? Are you in the colon cancer group? Okay. Dr. Dominic, what are the advantages of using things like the Cologuard and the others versus getting a colonoscopy? Are there some distinct advantages?
Yeah. We go back a little bit. There are the advantages really are convenience, and it's a way for people who find themselves in the situation where the discomfort of preparing for and having the colonoscopy is too much, and certainly for some people it can be too much. These can be an alternative for folks who the colonoscopy is either too much or just doesn't agree with them. But in terms of accuracy or how much information each test gives, the stool sample tests like the Cologuard, like the Shield, really don't hold a candle up to the colonoscopy, which is why if you have one of these tests and they come back as positive as something that needs to be followed up on, the next step is going to be a colonoscopy. So again, the main advantages of the take-home stool tests are really just convenience, and being able to avoid the discomforts of colonoscopy. But we always say that if you're able to get the colonoscopy, it's probably the best way to go.
We still have a couple of minutes more. So tell us a little bit more about the screening process. That when your van goes to the various community, what is the extent of the screening that is done there?
All right. So you're talking about the lung van?
Yes, the lung van.
Sure.
Yeah.
Let me just get this here. So lung cancer screening, in contrast to the other types of cancer screenings, is the only screening where the eligibility criteria contains a behavior, right? So with colon cancer screening and prostate cancer screening, basically they just check your age and that you have a colon or a prostate, and then that's it, right? And then with lung cancer screening, it's a little bit more complicated because there is an age requirement here, but there's also this requirement here called the pack year history. And basically what that means is someone is who is interested in for lung cancer screening to be eligible for it, they need to have basically smoked a lot for a long time. And sometimes it's really hard to find people in the community who are, number one, smokers, right? Or, smokers who recently quit. And number two, have smoked that amount of cigarettes in order to be eligible for the for the test. So the eligibility criteria is not only the clinical guidelines, but it's also the criteria that insurances use to determine if they will cover the test for individuals. So, we get questions all the time about folks who say, I got something going on for my lungs, but I'm not a heavy smoker. Can I get checked on this lung screening van? The answer is, unfortunately, that it wouldn't be covered by insurance. But if folks do have a particular lung issue they want checked out and they're not eligible for lung cancer screening, my recommendation would be to make an appointment with a primary care doctor, or even better, a pulmonologist or lung specific doctor. But in terms of the screening on the van, if an organization was interested in having it come to an event, the process is simply started by getting in touch with our lung van team, which can be reached through the same number or this website. They would have to determine if there's space at the event to park the van, because this is it folded up, but when it unfolds, it takes up 2 lanes of traffic. So the ideal situation for it is like a very large parking lot where they can, where you can have space to stretch its legs, so to speak. If it's determined that there's space for the van to come, kind of preparation and promotion is done over the next month or two. And that preparation includes having at least one, if not multiple, workshops where myself or someone else will come to the organization to give a very, a pretty detailed explanation of the process of getting screened for this lung van and going through these eligibility criteria as well. If someone attends one of these workshops or hears that the van is coming to the organization and is a candidate based on these criteria, they would simply call this number or fill out the survey here on this website. A nurse practitioner would get in touch with them over the phone, and they would have a telehealth visit over the phone. That's called a shared decision-making visit, where they would weigh the risks and benefits of this screening. And of course, determine if they're eligible based on this criteria. And at the same time, they will obtain pre-authorization for if the insurance requires it. If all of that goes through, and it can take about up to a week to get all of that set, then an appointment is made for the individual on the van, and they get to, on the day the van comes to the organization, that individual will, show up and get scanned at the appointed time. I will say that the van is not the only way to get the lung screening test. We do have, several brick and mortar sites around the city, and other hospitals and organizations also have this screening usually available at at larger hospitals. And the important thing for me and for our team and for the community isn't that someone gets the screening with our organization in particular. That doesn't matter to me almost at all. It's that folks are getting this screening with anyone, in the first place. One of the worrying things about lung cancer screening is that only about 5 to 10% of all individuals who meet this criteria in New York State go on to get this exam. So, 1 in 10 is not great. We'd like to, improve the rate at which people are getting the screening done for those who are qualified. And more importantly, catching lung cancer, not at the late stages, but just like with the other ones, at the earliest stages when it's small, localized, and easiest to treat. With lung cancer screening, it's a repeating process. So usually they ask you to come back once a year. If they do find something that needs following up, they'll usually schedule a follow-up sooner than a year with either more advanced scanning, and if necessary, a biopsy and treatment if that's something that is deemed necessary by the follow-up tests. This is all super complicated. So throughout this whole process, there's a coordinator, nurse practitioner, kind of explaining to you every step of the way, the reasoning behind each step, and the implications of all the different results that you get.
Okay, very well. I think we have like 30 seconds remaining before we get back into the main room. Thank you so very much, Dr. Dominique. We really appreciate this presentation. The breakout group is going to close now.
Thank you for having me.
All right, appreciate it.
Good afternoon, everyone. I'm Hildegard Reimers, Treasurer and Secretary of APC Community Services. I have the pleasure of introducing our speaker, and Ms. O'Keefe. Stephanie O'Keefe is a clinical social worker committed to advancing justice and empowerment for survivors of interpersonal harm and trauma. With more than 10 years of experience supporting individuals, families, and communities, she began her career in child welfare, helping families remain safely together through safety planning, therapy support, and resource coordination. For over 9 years, Stephanie has worked with Safe Horizon, where she has served as supervising social worker and now as clinical director of the Queens Community Program. In her current role, she oversees staff and provides support to individuals impacted by violence, exploitation, and abuse. Stephanie earned her Master of Social Work from NYU Silver School of Social Work. Welcome, everyone, and Ms. O'Keefe, you may begin.
Good afternoon. Thank you for having me here. I'm just gonna share or try to share. There we go. And I apologize, I've been having some tech issues today when it comes to the slideshow. So everything's been going slow. Okay, so today we're talking about domestic violence, intimate partner violence. So this is pretty much like a generalized overview. It's a lot of information all at once, but I could slow down or, stop at any point that anyone wants to sort of stay with that. Just to introduce Safe Horizon, we are the largest victim service organization in New York City. We do provide services to victims who have been impacted by violence, harm, abuse, exploitation. Our mission is to stand with those who have experienced violence, abuse, and exploitation, and we offer unwavering support and advocate for change. Our vision is really safety as a human right is really what we're trying to promote at this time. And so those who are familiar with Safe Horizon might know that we're a pretty large organization. We have a lot of different programs. I'm coming from the community programs. We have community programs in most boroughs. Our community programs provide supportive counseling, safety assessment, and planning. We do Office of Victim Service compensation claims for those who are eligible. We provide information, referrals, advocacy, and we do some community outreach and sometimes some workshops. So just some basic objectives for today would be to define domestic violence and identify risks, know what it might look like, and understand what to do, how to talk to someone who might be experiencing it, even if it's you that's experiencing it. And so typically I always start off by asking people what they think about domestic violence. I like to have more conversational trainings, presentations, but if it's preferred, I can also just sort of run through it. But even if you want to just think to yourself, like what is it that comes to mind when you think about domestic violence or intimate partner violence, which you'll hear me sort of interchangeably refer to. So these are not all-inclusive terms, but this is what some people might think about when they think about or refer to domestic violence, is we're talking about harm that's occurring in a relationship. Sometimes we also refer to it in terms of family violence, because violence can happen between family members. But these are oftentimes the terms that we hear people refer to. And so sort of defining intimate partner, because I tend to use intimate partner violence or IPV more frequently because it's more inclusive to those relationships that aren't happening in a home. You know, domestic violence doesn't have to be in someone's home. And so defining what an intimate partner is would be someone where there's an emotional connection, some frequent contact. Really, we think of like what a really, really close relationship, typically a partner, an ex-partner, girlfriend, boyfriend, child of or the other parent of a child. That's typically what we refer to when we think about who an intimate partner is. And then defining domestic violence. So domestic violence is really defined by an ongoing pattern of behavior that asserts control or dominance by one person over another person. We oftentimes use the phrase coercive control. It's basically pushing someone into doing, thinking, feeling something that they wouldn't otherwise or don't want to. Those means are also can include violence or anything that would cause harm to the person. Thinking about power, because power is so central to any type of abuse. Power in the context of relationships is the ability to control someone else. In healthy relationships, that's shared, and in consenting relationships, it can be go from one end to the other, but the key part of that is consent. You know, coercion is not consent. So abuse happens when someone does something that causes someone to feel powerless in a relationship. Just sort of running through some of the different types of abuse. We oftentimes, you know, the first thing I think a lot of people think of is physical, which is like the kicking, punching, strangling. There's also verbal, using name calling, putting someone down, psychological and emotional, which is more, you think about the gaslighting, having someone question their reality and sort of blaming, using this sort of negative self-view. You know, I oftentimes refer to people as like eroding their self-esteem, because if you don't have a self-esteem, you're not likely to either stand up for yourself or have any power in a relationship. Sexual abuse does occur in domestic violence as well. Just because you're in a relationship does not mean you're expected to consent to sex or sexual acts at any time. And we oftentimes see different types of sexual abuse in intimate partner violence, where someone may not use birth control or restrain someone from using birth control. Financial as well, restricting someone's access to funds, which is anything that would basically empower someone is restricted in an abusive relationship. Cultural, spiritual, religious abuse also occurs, where if someone is restricted from practicing their rituals. An example that I've seen before is someone sneaking pork into someone who's Muslim's food. You know, so there's different ways to really be coercive and harmful in a relationship. So this wheel is sort of adapted from the Duluth model, the power and control wheel. There's many different versions of this wheel that include different identities like race, immigration status, gender. But in the basic form, what this wheel does is it shows you different tactics that someone might use in a pattern of abuse. And so signs that someone might be experiencing domestic violence can include feeling anxious. Hypervigilance, which is also a post-trauma reaction, is sort of like that jumpiness or feeling like you have to always look over your shoulder. So you might notice someone is doing that. If they're sort of not allowed to really do things, they always have to check in with their partner. They need permission. That might be something that's a red flag. I always say that I'm hesitant to give red flags because a lot of times there aren't any. And just because one of these things is happening doesn't necessarily mean it's a domestic violence situation. What we're really looking for is a pattern, like a series of behaviors that are being used to control someone. And just to go over some statistics and really highlight that disparity, we do know that both men and women and non-binary can all be victimized. Anyone can be a victim of domestic violence. The statistics seem to show 1 in 4 women, 1 in 7 men. There's still missing statistics, I think, around, you know, expanding beyond that. But as Dr. Scott said earlier, statistics only show but so much. This is only what's reported, and it likely is happening more than what this is saying. Black and Hispanic women tend to be victimized more frequently. They're disproportionate, and it thinks she was mentioning statistics earlier around homicide, and I think it's about 1 in 5 homicides are perpetrated by an intimate partner or former intimate partner. So it's just really important to sort of contextualize what we're seeing. So how do we address suspected domestic violence or intimate partner violence? What do you do? We tend to really encourage folks to address it with curiosity. Ask open-ended questions. Express if you're concerned about someone, but avoid too much judgment in that inquiry. We really want to focus on the person and their safety rather than the other person who's causing harm. You may want to mirror their language. So if they refer to themselves as a victim, you can refer to them as a victim. Asking, what it is that they need as opposed to telling them what it is that they need. Validate someone's feelings, expressing, I can see that you're scared. And most importantly, listen. I think that a common theme that I'm hearing from today in general that Dr. Scott really touched on is a lot of what is happening that's harmful for people thrives when it's happening in silence. And so the more we talk with one another about these things, the more we bring it to light, raise awareness, and can address it. But we really want to help people have a predictable and clear understanding of what their options are. And so if it's a family or friend, or if you're not super familiar with the different services that are out there, starting with, well, this is a place you can call to start getting answers to your questions. Things to avoid doing. Don't be judgmental. I think it's really important not to say, well, how could you let this happen? Or why would you go back to them? There are complex reasons why people might not leave a relationship immediately. A lot of times when we introduce domestic violence as a concept, we talk about that analogy of a frog in boiling water, where you put a frog in lukewarm water, it'll probably sit in that pot for a while. It feels normal, it feels fine. And as you turn up that heat, it can't get out, right? But if you were to put a frog in a boiling pot of water, it would jump out right away. So relationships the abuse tends to escalate over time rather than be immediately. No one would get in a relationship with someone who was initially not being very nice to them or physically hurt them in some way. A lot of times it starts out with name calling or controlling behaviors and might escalate to violence when the harming party needs to adapt their tactics in order to maintain that control. There are certain risk factors like what Dr. Scott touched upon is once pregnancy occurs, that might be a higher area where people see abuse happening. Leading me to leaving an abusive relationship is not always what the harmed party is looking to do. There are instances where it might be more safe for that person to stay in the relationship. We know that lethality with domestic violence increases significantly at the time of which someone is leaving a relationship. So that's really that key area where we want to pay attention to safety. It actually takes an average of about like 7 times for someone to leave a relationship that's abusive. So these are some words that sort of reflect the reason why someone might stay in an abusive relationship. You'll see the big ones, guilt, love, shame, fear, tend to be very, very heavy impacting in people's. Sometimes I'm hesitant to call it a decision because sometimes it isn't a decision. That's the coercive piece of it, is that sometimes people feel like they don't have a choice. They might be financially dependent. They might have shared children. It might be a cultural implication in leaving a relationship. But I think what we try to really do is trust individuals to know what's best for them and offer support in whatever options they might have. And so these are some examples of, and I'll acknowledge that this is a very old study. This is from 2004, but this was a survey of different safety planning strategies that people have used and what's been most helpful. And I think this also sort of dispels some myths that people have about, like, countless times I've heard people say, I would never get in a relationship, I would fight back, or whatever the case may be that people have said. It's not that simple, right? So as you can see that sort of on the bottom of this, what's been less helpful is fighting back. trying to negotiate using weapons. It oftentimes hasn't worked out the way that people needed. And sort of at the top of there, staying at a DV shelter, which has some of its own complications in that it's less, we know that domestic violence shelter is less accessible for single adults, for instance, and more accessible for people who have family, who have children. But talking to someone, getting an order of protection, keeping all those things that people need, those tend to be high. And I can't say that there's one way to safety plan with someone because it really is individual to people that you talk to. And so thinking about the impact of domestic violence and intimate partner violence, something we see among our clients is that there tends to be trauma reactions. Domestic violence is oftentimes experienced as traumatic. Defining trauma could be an experience of an event or a series of events that give a threat to your life, your well-being, your integrity, and it really overwhelms one's ability to cope. So things that you would typically do to stabilize yourself don't work when you're experiencing something traumatic. And as a behavioral change, it can lead to isolation, drinking more, changes in eating, changes in sleeping, feeling depressed, sad, angry. And we really see a lot in terms of those like thinking errors, or sometimes we refer to them distortions. Trauma-based distortions tend to change the view of the world in which someone is experiencing other people as harming parties. They might reenact between bystanders, victim, and offender or harming party. And they might think very negatively towards themselves. I should have known, I should have done something different. It's my fault, I caused them to be angry. And because this is a health summit as well, thinking about what really the impact of domestic violence, IPV, can have on one's health and mental health. This is coming from the CDC. The CDC has changed in the outlook of what domestic violence in the current administration, but it is considered a risk to public health. And so one thing that we've noticed is that there's definitely comorbidities in survivors meeting criteria for PTSD. That many of them are more likely to be diagnosed with an anxiety disorder, which sort of falls under that PTSD umbrella, and 6 times more likely to have a substance abuse disorder. Post-traumatic stress disorder and substance use disorder tend to have high comorbidity, meaning they happen together a lot. And these are just some of the impacts. We also know that there's health impacts. Anything that would exacerbate like that stress, that increases stress, exacerbates physical health. We know stress is a killer. So when you think about how, impacts for heart health, bone health, and I think just general anxiety tends to be higher impacts for this. Not to mention the behaviors that someone might engage in as a means of extreme coping, meaning as a way to deal with the abuse, with the feelings that are happening. People might engage in more risky health-wise behavior like smoking, drinking, and those obviously have impacts on one's health. And so in thinking about what to do about when you're safety planning with someone who might be experiencing domestic violence, or if you know someone, think about how someone has already been remaining safe. People are very adaptive. We really do fight to stay alive. And so our behaviors, our thoughts, our feelings all sort of adapt to what will keep us going. So how has someone been doing it? And really sort of building from what they might need from that point on and what's been working. And I always say, the first thing we think about is physical, but there's a lot more to think about as well. Like, how is someone financing themselves? Because we know that you need money to survive. So what is someone's need financially? Or what are their needs emotionally? Do they need that support, that reassurance? So always keeping in mind those types of safety concerns as well. For the purposes of Safe Horizon, for what we do, we focus on immediate risk when we talk to someone. So that means what is happening in the next 24 hours that might need attention. And then we ask if someone's interested in hearing more about services that could be useful for them, which we'll get into shortly. So be honest and transparent. We definitely have limitations in the city for what people might need. More often than not, we see housing needs, and as everyone knows, we are in a housing crisis, and that tends to be more challenging. But so we just want to be honest. We want to be clear. You know, people need predictability, and predictability increases someone's sense of safety. And so this is just some more sort of how to safety plan, connecting with a trusted family or friend, really talking about it. You know, I think there's a lot of misconceptions about how people will be perceived when they admit or say that they've been victimized by someone else. Even sometimes there's concern for the person who's harming them. You know, not everyone wants to see the person who's been harming them in jail, for instance. So I think that there's different things to consider, but that's why you start with someone that you trust. Keeping all your vital documents in a safe space, so if there is a need to leave, you can do so without risking losing those. You can contact a victim service provider to discuss what your options might be and utilize the hotline. Safe Horizon runs the citywide hotline that also connects people to domestic violence shelter. And as I said before, safety planning is really unique to every person and family. And so going through some options of what someone can do if they find themselves being victimized. If you're in a situation where your life is at risk, we always tell people, I mean, most places will say call 911, or most importantly, get out of the situation as quickly as possible. That's why we say keep your vital documents, keep some extra cash, get out of the situation, go to a trusted person. If you are choosing to report to the police, these are different methods of how you can do so. You can call 911 and they would have to respond to you. Typically, they'll send out domestic violence unit or officers to the situation to interview both parties. The police will decide whether or not to make an arrest. This is where we say, you know, just to report what has happened the best that you can. You know, there are circumstances where the police have to arrest none or one. So that's just always something to keep in mind. You could file a report at your local precinct as well if you're not calling 911 for an immediate incident, but are thinking about reporting something that's happened after the fact. You can do that. And we do have advocates in the precincts. We have DV advocates in, I think, almost every precinct in the city. So those are people who can help facilitate reporting as well. And I should say police may take a written report because I can't definitively say whether or not an officer will take a report. It's up to the police ultimately. But that is, you know, typically they would write a report. If they come to you, you'll get a domestic incident report. And if an arrest is made, criminal court would be involved as well. And so moving into family court. Family court is where you could petition for an order of protection. So I mentioned that if an arrest happens, it goes to criminal court, and that's another area where you might get an order of protection. You can only get a criminal court order of protection if an arrest is made. You cannot walk into criminal court and ask for an order of protection. You can walk into family court and petition for an order of protection by outlining incidences that have occurred that would reflect a danger to you. So we do have advocates there as well who can help sort of facilitate in getting that petition written up. What typically happens is you write a petition, you wait, you get seen by a judge, and the judge decides whether or not to grant that temporary order of protection. At that point, that order of protection needs to be served on the harming party. It is not active until it is served. So oftentimes when we're safety planning with people, we talk about, well, how might it be, like what risks might there be once the harming party receives this petition? Because sometimes, and does this person feel like the harming party is afraid of getting arrested? Because the reality is that once someone is arrested, they will be released. And then, so what if some people do not want to get arrested and they will do everything not to. So it could be very effective, but we always want to make sure again that it's tailored to that person and what they think will work. After that temporary order of protection is granted, they'll be given a court date in which the harming party will be expected to present, and they'll tell their side, and then it'll go from there. And so something to think about, because sometimes family court is also involved if there's children. If you ever find that someone you know or you is having to present at family court or criminal court and you're afraid and you don't want to wait in that part while with the harming party, you can always wait in one of the Safe Horizon offices and they can call you in once your case is going to be heard. And just looking into some other options, again, like I mentioned, the domestic violence shelter, you can call our hotline and assess to be placed in shelter. If there's not vacancy, we would suggest calling back. And I know that that can be very trying for many people to have to call over and over again. That's why we try to be transparent about it. It is all dependent on what is available. The domestic violence shelter through the Department of Homeless Services, it's not a specific domestic violence shelter, but that you can get assessed at DHS for domestic violence. Encourage getting support from family and friends. There's also a family justice center located in every borough. The family justice centers are really a one-stop shop. If someone has a multitude of needs, let's say they don't know what to do and they need a place to start, going to a family justice center could be very helpful. They have reception desk staff that will help sort of identify what your immediate needs are and direct you where you need to go. They're also where individuals can be assessed for FEPS-B vouchers, which has its own set of requirements. So I would never say you could just go and get a voucher, but it's where you could talk about what your options might be. And of course, any victim service agency like Safe Horizon as well is a place where you can explore what your safety planning and options might be. And so I always just put this slide that especially oftentimes when you refer to any organization, there's a lot of mandated reporters. Things have changed in the expectations around mandated reporting, but just we always disclose that we're mandated reporters ahead of time so that it's never a surprise. We always want to consider that, you know, especially with ACS, there's a disparity in investigations, and so just always note that. And just some of our basic info, the community programs, like I said, that's the programs that I work out of. And that's our direct helpline. That's where we get our intakes. So typically someone would call, leave a message, and we work to get back to people within 48 hours, but with the exception if it's a Friday, you know, it would be Monday. And then our hotline and of course our website. And I think that brings us to the end of the sort of formal presentation. But as I said, I typically like to be more conversational and hear from you all, you know, what your thoughts or what your experience might be and any questions you might have. So I will.
So we could, I think we have 20 minutes remaining in the session. So we, I didn't see any questions in the chat. We have couple guests. Would you like to, do you have any questions? Ms. King?
And I know I ran through that really quickly, so I apologize. I just wanted to make sure we had time, because usually I go over time.
May I ask a question?
Mm-hmm.
Thank you so much for the informative presentation, Dr. Stephanie. Question, what does the victim of abuse do if the abuser threatens to kill them if they leave? Like 1, 2, 3, what? Because sometimes it's like the abused person can be like a deer in headlight. They don't know what to do.
Mm-hmm.
Please. Thank
Right.
you.
No, I appreciate that question. And it's something that we actually hear a lot. What I would say is it really depends. You know, if someone has a history of escalating physical violence, that might indicate that they're really at a high risk that that person might follow through with that threat. You know, in these types of cases, I really rely on the clients that I speak with to provide the context of that being said, right? Because people might verbally, like someone might make that type of verbal threat regularly and has not gotten to a point of physical violence. That's not to say that they can't get there. But of course, if someone's saying, this person told me that he's going to kill me, and I'm really scared that he's going to kill me, you know, that might be a situation where we start thinking, okay, you need to leave immediately. But also we want to plan it out because we know that when someone leaves is the highest risk of mortality. So I would first say, like, what does that person need in order to get out of that relationship? And how could they stay at that home in the next 24 hours safely. So if it's the case that if they stay, they are more safe, like they are safe until they figure out a way where they could more inconspicuously leave. Like maybe they need to get to a shelter, but maybe they need to wait until that person is at work. So thinking about like when is the most opportune time to get out of the relationship, rather than in that moment run out, because if that person tries to leave in that moment, they might be at a higher risk. But I would also never tell someone not to call 911. So it's not that I try not to be super directive, but if someone is afraid, that person has a weapon and they're saying, I'm going to kill you, that might be a situation where you lock yourself in a room and you call 911.
Thank you so much. I appreciate that. I'm gonna wait for somebody else, and I have another one, but let me wait.
And I want to emphasize, I know that this is a really, really tough conversation to have. Like I said, I oftentimes say that we really want to avoid, and the field is shifting too. I mean, even at Safe Horizon, we just got a grant for restorative justice practices to use for domestic violence. We don't know how we're going to implement it yet, but it's something that's going to shift to give another option for people who maybe don't want to do that criminal justice route. So it's not a simple, there's no simple solution to domestic violence outside of continuously talking about it, offering services to people who are causing harm as well, because we know we can't, we need to treat that as well. And offering more options for people. I mean, I think I so much of what Dr. Scott resonated with me, what Dr. Scott said, and just even advocating for housing, poverty, like these are all, when people are in poverty, it's a breeding ground for domestic violence, high stress situations. But it's very complex. There's a lot of different factors.
Anyone else? I believe we can.
Oh, yes. Hello. Hi. Okay. I wanted to ask, what is one of the most misconceptions that you find with the victims that cause them to go back? I know you said sometimes it takes about 6 times at least for them to go back, but has there been like a common misconception from them that they feel like they have to go back? Like, is there anything in common?
Oftentimes, and this is all anecdotal, so I'm not using like statistics, but what I see a lot is shared parenting. I also see a lot of, I mean, people are in love. They feel a connection to this person and believe they might change. And certainly as a social worker, inherently I have to believe that people can change. And I do, but people have to want to change. And so sometimes there are little signs that someone could change, and then sometimes you're like, that person is in it, and unless they really decide to do something different, they're not going to change. So that's where I think even with staff, like we really have to work on putting our own judgments aside and acknowledging, okay, so you're going to return to this relationship. What do you need to be most safe? Like, so if you're going to be here, what do you need to be safe? Because I think that really, not to be cliche, but the most common is, well, they said they would do something different. They changed. They apologize. They seem really remorseful. And that's not to say that people who cause harm can't be remorseful, but is it enough? Like, is that person going to change?
Okay. And something else I would say for Verizon, do you offer like trainings for like maybe the victim that the person, the abuser is the breadwinner, the one that takes care of them? Do you have some kind of services like that that you offer to the victims?
Do you mean like
To
economic
help them?
empowerment type,
Yes.
like workforce? So that we typically refer, it's been on my mind because it is something that's so critical and important. And that a lot of people, because to your point also, why do people return? Money? I mean, if you have nowhere else to live, how do you
Yeah.
survive? We live in one of the most expensive cities, I think, in the world. And it's becoming less and less accessible for New Yorkers and people who have lived here. So you need money in order to, like, housing and money. Those are the two biggest barriers that I see on a regular basis. And that's a long-winded sort of non-answer to the question of we don't have a specific training or program, but that's not to say that we won't ever. And I think Sanctuary for Families, for instance, I think is an organization that has had an economic empowerment program. And I think that you can access through a family justice center. But I'm always on the lookout for those types of programs because we do try to look for where someone might be. If we can connect someone to job training, I think even through HRA or citywide, there are different job training programs, not necessarily specific to domestic violence, but different opportunities.
Okay. And one more question about with the children of the victims. Do the victims sometimes go back because they feel they're taking away the child, maybe from the dad or from the mom, that they give in? Do you find that happening?
That's certainly something that can happen. I'll also say that family court and custody can get so messy. And so sometimes it's just easier to just figure it out with each other than to be bogged down by like an ongoing family court battle. And again, anecdotally, I feel like I see it more when people have babies, like when they're new parents versus the older children. I feel like with older children, they do try to leave as well. But there's a lot of, weaponizing the systems is something we see a lot. We see false ACS claims get called against people, false police reports. One person petitions a family court order protection, the other person petitions one back in retaliation. And so, those are some things that we've seen that might cause someone to decide to just stay in the relationship or try to keep the peace.
Okay.
I have to say, like, if I really am thinking about why people stay the most from what I've observed, it's low self-esteem and, feeling like that person gives them something that no one else can.
Okay. Yes. Well, my hat goes off to you. Congratulations, with all that you have to deal with when it comes to being listening and then not trying to be opinionated and trying to help save the world. But, just offering the services that's very good that Safe Horizon exists.
Thank you. I appreciate that.
You're
And
welcome.
we do it together. We all rely on each other to sort of work through it. And I think that's why it's just so important that people talk about it.
Yes.
Because I think there's also this general, and this I've heard this from others, that there's this cultural expectation that what stays in the home, like what happens in the home stays in the home. And there are times where that may be totally appropriate, but when it's used to cover up harm, what are safe ways that we can still talk about it without putting families at risk?
Yes. Okay. Oh, good. Thank you.
Yeah, we're not hearing you, Hildegard.
You had another question?
Yes. Yes, I have another one if nobody else wants to go. What are some signs a partner can look for in a courtship relationship that the person they are intending to marry may be a potential abuser?
So sort of thinking about what are signs someone could be harming them.
No, let's say they're courting somebody. What should that person look for, the girl or the young man, that the person they are thinking about marrying might be an abusive person?
So it can be tricky because a lot of times people don't present how they're going to be later on in the relationship. But what I would say is things to think about are things moving very quickly. And I'm always hesitant because I don't want people to not feel like they can fall in love. Like you could fall in love, and sometimes that does happen quickly, but is it happening at a pace that feels like it's being pushed? Like people refer to like love bombing, where this person is just over the top. Me personally, I would look at their past relationships because oftentimes if someone is being harmful, they've been harmful to someone in the past. So not that they're going to admit to anything, but just something to think about. But are they asking your whereabouts constantly and in a way that it's really it's the guise of being protective? Because sometimes people will say, well, I'm just protecting you. That's why I want to know everything you're doing, all your passwords, and follow your location, you know, and the reality is that could actually be something that's really controlling. You know, I had a client who would say, oh, well, he's so nice. He makes my smoothie every morning. And I'm like, after talking with her and noticing again that there's other things going on, because that could be very nice. It could be very nice to have someone make you breakfast, but it could also be a way of controlling someone's intake. And so just like looking for, you know, I don't want people to be so hypervigilant that they can't enjoy a relationship, but if something feels off, it probably is. So just noticing, you know, how are they treating, are they isolating you from your friends? Isolation is a very key strategy that people use to keep people in control. So do they always try to, and it could be small references. It may not look like you're not allowed to see that person. It could be that you notice that they have something negative to say about every person you spend time with. You know, and keeping you like just constantly badgering you. You have to check in with them all the time. So, and blame. Do they ever take blame or accountability for anything? Or is it always your fault? Because oftentimes I'll say to my clients, was everything your fault? Could everything possibly be your fault? Most of the times, no. But it starts to feel that way because someone is in these small ways constantly telling you that it is. So it's very subtle, I would say.
Thank you very much. Appreciate that.
Sure.
Questions? We have 6 more minutes before the session. I mean, going back to the news, especially the case in Miami, of that I believe she was a city council. You know, you get a sense that it went from one to 100 in that particular case. You know, everyone around her neighborhood.
In which one? Sorry, I couldn't hear too well.
Yes, a little volume, more volume, Dr. Hildegard.
Can you hear me?
Now I can, I think.
Yeah.
It's a case, you know, I remember, you know, in Florida, I think she was a city council. It sounded like it went from 1 to 100. And this is somebody educated, you know, in the public eye and all that. And for her to die like this, and it makes you wonder, you know, what else can be done, you know, how you raise awareness. What did she miss or did the family miss?
Yeah, I know what case you're talking about, and that was, you know, as they all are, but that was so heartbreaking to see someone who was so accomplished and worked so hard. And that's why I tell people anyone can be a victim, literally anyone. And I think that it really shows just how manipulative people can be to really get into someone's head. To the point of it going from like 0 to 100, that can happen, you know, but oftentimes it happens once someone's already hooked. When you have someone, I mean, who knows if he had something over her, you know, we don't know the details of the situation, but a lot of times people feel ashamed and they don't talk about what's happening to them, or they don't believe it themselves. You know, to believe that something bad is happening to you is to believe that you're in risk of danger, and that feeling is terrible. No one wants to feel scared, so it's much more empowering to, or I shouldn't say empowering, it's much more protective to believe that it's not what's like you question your own reality. Like that isn't what really happened. Oh, they didn't really mean that. That's not this. You know, that couldn't be me. And people who are harming you or people who are abusive adjust their tactics to what works.
Yeah. Mrs. Hildegard, like somehow we're not hearing you too clearly. I don't know.
How could maybe my voice is not projecting it? I said there's somebody else.
Yeah, hear you now better. Thanks.
Do you have any questions? We have 3 more minutes. Thank you so much. It's okay, you know, such a great presentation, and I think it's much needed.
Mm-hmm.
To believe that that it should be taught in medical school, especially coming to the emergency room. I've been working in healthcare for many years, so many cases of domestic violence, and seeing that, and it's really critical that you actually see the person coming to the clinic, speaking to a social worker. But you know, definitely there's more training needed for healthcare workers, you know, physicians. Thank you so much for the work that you do.
Oh, thank you for inviting Safe Horizon to have this conversation. It's really important. Thank you. And thank you to those who joined. I know it's not a uplifting topic, but the more that we know, the more we can do about it.
I crave one more. Could I ask one more question, please,
Mhm.
Ms. Hildegard?
Yes.
Now, sometimes you have a loved one who's being abused and you want to help. How can I help without feeling I'm aiding and abetting the person to get away or this kind of stuff? And,
Mhm.
you know, my own fears that if this thing goes south, then I'm involved. And
Mhm.
what can I do and what can I not do?
Well, so that might involve sort of your own safety planning, right? So to think about the things, both of what you would need and what that other person needs. I try not to overthink it. I try to say, well, what is that person saying they need? If they're trying to leave a relationship, what do they need to be connected with? Is it legal services? If they're married, do they need a divorce? Um, is it identifying a safe place for them to stay? Um, I think there's just starting with that initial question of, are you scared? Are you afraid? And what do you need? It might just mean that they need someone to talk to, just to talk things through. And if you don't feel comfortable, could you connect them to someone who could?
Yes, yes.
This way you don't feel like you're that direct tie.
Because I remember as a pastor, somebody came like 11 o'clock in the night, husband beating him up, and myself and wife went with the person to the police. And the police came back and told the abusing husband, if you do it one more time and I get another complaint, I'm going to arrest you.
Oh,
So
wow.
I don't know whether
Okay.
I did right or wrong, but that's what we did.
I think it sounds like you did what you could in the moment, given the
Yes.
information that you had. So
Mhm.
it's, when we're in crisis, we're not like thinking through towards what's going to happen in the next week. We're thinking what is going to happen now. And so it's so hard to tell. I don't think there's always a right or wrong, but it sounds like you were there for someone and did the best that you could.
Yes. And he was abusing indeed. Yeah, it
Mhm.
was crazy, man.
Thank you again. Yeah. 19 seconds. I guess they'll take us to the main room now. Thank you.
Yes, you were saying something?
I said we have 2 seconds, literally.
Oh, 2 seconds.
Yeah, it'll take us to the main room. Yes.
Okay. Thank you, everybody. And you all did very well. And God bless you all. Wonderful
Thank
information.
you.
You're welcome.
All right, so this is an overview of prostate cancer. Prostate cancer burden, cancer overview, prostate cancer symptoms and risks, screening and summary is all that we're going to cover today. Dr. What was her name? The doctor who was just speaking, she did an excellent job.
Sandra Scott.
Dr. Sandra Scott. She did an excellent job in really laying the foundation of this whole conversation. I was really impressed with everything that she covered and how just thorough she was. So I'm going to reiterate a few points. Did you know in New York State, prostate cancer is the most common cancer among men after skin cancer? In New York State, prostate is the second leading cause of death in men after lung cancer. And remember, she mentioned it's just because men, specifically black men, are not checking enough. They're not screening. And that is what makes the difference between black men and other races of men. And that's why we're seeing these numbers. I want everybody to visualize, especially now where we can really see a full stadium and it's NBA finals season. Imagine the Barclays Center at capacity. That's almost 15,500 people. Okay, so this is the number of New Yorkers that are diagnosed every year with prostate cancer. Among those, 1,700 die of the disease. Look at all of these people. This is a representation of the state of New York, the cases in the state of New York. Okay, combined, this is almost equal to the number of the people in the Barclays Center. Or just, if you're not familiar with the Barclays Center, just imagine another huge stadium. In New York State, Black men are 1.5 more times likely to get prostate cancer and almost twice as likely to die of the disease as compared to white men. Black men are more likely to develop the disease earlier in life, but more likely to be diagnosed at a later stage when cancer may have spread because of the lack of screening. Race does not increase risk for these poor health outcomes. Rather, racism works on several levels to contribute to these cancers and health disparities. These inequities can be found in access to health care, insurance coverage, discussions about screening, and quality of treatment and follow-up. And these are some of the reasons why Black men are reluctant to go to the doctor. They may feel intimidated by that conversation with a healthcare provider. They may not feel that it's a safe space for them to express themselves, okay? So many different factors. Now, just to put a face to prostate cancer, many of these individuals, and if I like the interactive part, but we'll skip that here. But if you recognize any of these individuals, you can shout it out yourself. We're going to go through it. It's Nelson Mandela, Sidney Poitier, Guillaume. His last name wasn't Guillaume. He's Benson.
Benson,
right?
yeah, Benson.
Right, Guillaume. I want to give him, honor his actual names. Guillaume, I forgot. Ken Griffey Jr., Al Roker, and Colin Powell, right? So they all had prostate cancer. So it's not, just in lower socioeconomic levels. It can really affect anybody. So let's talk about what cancer is in the first place. So cancer is a condition where abnormal cells grow out of control. These abnormal cells form masses known as tumors. When cancer cells grow out of control, they can crowd out normal cells, and this makes it hard for your body to work the way they should, right? So you can see here, I really like this because it really shows these are the normal cells. Abnormal cells develop, they multiply, and they're gaining their own blood vessels. They call it angiogenesis. So it's really an interesting way of seeing it as something foreign now, kind of, it's almost like a parasitic relationship almost, where this is feeding off of your own body, right? It's feeding off of now your resources and growing its own blood vessels, okay? And you can see how this can spiral out of control, and it can attack your own well-being because it's stealing resources from your body, and that's what we would call a malignant cancer. Okay. What causes cancer? These are many types of cancers with many possible causes. Many things affect a person's chance of getting different types of cancers, and some things that increase risk for many cancers, not all, include age, and these are things that you should know to discuss with your doctor. For example, age. Cancer is more common in older people. Although cancer can be diagnosed at any age, if you're at a certain age, it may be time to start checking. In terms of prostate cancer, we're talking about 40 and above, between 40 and 69 roughly. Family history. This is a big one because family history is something that not only is a big stigma in Black, African American, the African, the Black diaspora. Within the family context, there's a taboo, for lack of a better word, where we don't really discuss what a particular family member died of. They just brush it away. She's gone. We don't really speak on those things. It's time to have those conversations within your family and know what uncle, grandpa, father, brother died of. In this case, I mentioned the males in the family because we're talking about the prostate, which is only specific to males. But you should understand if you have daughters in your family, if there's breast cancer, ovarian cancer, colorectal cancer. These are things to know and to talk about, so you can discuss with your family and set a precedence by letting your doctor know that there is a family history, okay? Tobacco and alcohol use, diet, which Dr. Scott spoke of, which I definitely am a strong believer in, lack of physical activity as well, and having obesity, okay? So what is the prostate to begin with, all right? She mentioned earlier the digital rectal exam. So this is the rectum right here, okay? This is where we defecate. So that's, right? That, and you would see why a doctor would perform a digital rectal exam, because they're trying to feel this area here. Now, do you, Claudia, when I move my mouse, can you see it on the screen?
Yes, I can.
Okay, wonderful, wonderful. Okay, so the digital rectal exam, which is not the first test done. This is later on if a PSA is found to be problematic. Okay, so PSA is a blood test. This is what we're advocating as the first line of combat. Let's put it in those terms. The first line of defense is getting your PSA, which is a blood test. Later, if there is issues, you would see they would do a digital rectal exam, which means putting a finger here and seeing if the prostate is bumpy, is it rigid, is it inflamed, right? And a doctor could feel that by pressing this area here. You can see here also that I want to highlight that it's close to the bladder, and this little tube here that's called the urethra, okay? So the bladder holds the urine, right? And the urethra is the tube or the hose that allows that urine to flow out through the penis. But if your prostate is inflamed, if your prostate is growing, has growth, abnormal growth, it's pressing against the bladder. It's pressing against this tube here. And so you would experience painful urination, a frequent need to eliminate because something is pressing against your bladder. It would be hard to finish off all of that urine because something is squeezing the tubes over here. So all of those symptoms, now you can understand why there would be painful urination, painful ejaculation, blood in the urine, blood in the ejaculation, right? Because all of these glands here, right, the prostate gland, the seminal fluid is coming from here, right, going into the prostate gland. You have the urethra, you have the bladder, so very sensitive area all through here. So I think that's enough on that. What is prostate cancer? So cancer, that starts in the prostate, okay? Those abnormal cells that we talked about earlier, that abnormal growth, it's growing in the prostate. So in this area right here. And it's a gland, mind you. You have a glandular system all through your body, okay? This is the gland that from bottom to up, this is the lowest gland. And all the way to in your head, you have glands, okay? They regulate hormones, they regulate different things. But here, the prostate would be, seminal fluid and things that would carry the sperm and create the sperm and carry it out. Okay? So as we get older, as we age, the prostate naturally grows. The increase in size is common and not usually cancer. Okay, so it's just because it's growing, there is an enlargement here. We can see from this size to this size, there's an enlargement, but it could just be because of older age. That seems to be normal. Symptoms of prostate cancer, problems with urination, which we covered, the painful ejaculation, blood in the urine or the semen, difficulty in having an erection, pain in the back, pelvis, or hips that won't go away, okay? These are all things to be mindful of. And if you're a man, you would know this. If there are women in this chat, in this breakout room, if the male in question is getting up frequently to go to the restroom, they're having pain in urination, they're not eliminating all of the urine as easily as it once did, to just rid and empty out the bladder. If you should know these symptoms as well. So because most men, as we stated, they just are reluctant to go to the doctor and reluctant to even speak about problems, because sometimes for a man, problems equates weakness or inability to solve those problems, and all of these stigmas and socioeconomics and all of these other factors, racism, come into play, and it creates reluctance for the male to actually try to solve the issue. Who's more likely to get prostate cancer? Black men, older men, men with a parent, sibling, or child with prostate cancer. So that family history, as you're older, and if you're a Black man, definitely pay more attention to the prostate and the screening. So prostate cancer screening means looking for cancer before a person has symptoms. This can help find cancer at early stages. PSA test is the prostate-specific antigen test. Okay, it's recommended for prostate cancer screening. This is the best test that they have, the primary test, before the digital rectal exam. Okay, so blood tests that measure the amount of prostate-specific antigen in the blood is the PSA. Digital rectal exam, a digit is a finger, and so that's why they call it the digital rectal examination. Okay, we covered that and what the doctor is actually trying to feel. Black men with a family history should talk to their healthcare provider about prostate cancer screening and their increased risk for prostate cancer. As stated, men ages 40 to 69 should talk to their healthcare provider about the risk for prostate cancer and whether screening is right for them. Screening is not recommended for men ages 70 and older. The reason being because prostate cancer amongst the various cancers is the slowest growing cancer. So remember, these are a few takeaways. Prostate problems and prostate cancer are very common. Black men and men with a family history of prostate cancer are at a high risk of developing and dying from prostate cancer. Men at high risk should talk to their healthcare provider about prostate cancer screening. Men ages 40 to 69 should talk about their prostate cancer risk with the healthcare provider and if screening is right for them. Okay, I'll open it now to questions. I'll also just put this back in the chat. Let me put another link here that you can check that out. But let me get back to the Zoom and stop. I'll continue sharing my screen just so I can see you. And if you want to hit that link. But if anybody has any question whatsoever, feel free to put it in the chat. Feel free to come on and ask your question. No question is a bad question. And please, if you can, we do need this information for our state requirements in doing this work. So if you can, please fill out the survey. It really helps us in doing our work. So we're Weill Cornell Medicine, just to let you know, if we didn't emphasize that enough. We're with New York Presbyterian and Columbia University. We are specifically with the Meyer Cancer Center and community outreach. So this is what we do within specifically my particular program is centered within Brooklyn and within the Brooklyn area. And, you know, my focus is Black men. So if you're interested, if you are a Brooklyn resident, if you have any organization that you'd like us to come to and do a presentation, even offer more than the presentation, let us know. We're definitely here for that or for these types of education sessions. So I'm sure there has to be at least one question in the chat, even if it's a silly question or you think it's a silly question. Feel free to ask, feel free to come up, unmute yourself. I think you have that ability. And feel free to ask. I think Dr. Scott brought up an interesting point that most boys don't know that they have that gland. Like, that was a really interesting point. But at a similar age, we would be teaching young ladies the glands that they have, right, and how to care for them. So early health literacy is imperative. I'm a big believer in that. And yeah, if you guys don't have any questions, I'll just let me stop sharing my screen. Thank you all for your time today.
Thank you, guys.
Thank you. Okay, so I actually have a background in healthcare as a healthcare administrator. I'm retired now, but I used to work for the city hospital system, Kings County. And at one point I was overseeing mental health clinic and also HIV/AIDS services. So I encountered a lot of situations with people who were dealing with severe mental health issues, in some cases that led to their, HIV infection. But in a personal way, I've also experienced in my family suicide, attempted suicide, murder-suicide. Not all recently, but just in the history of my family, these things have happened. And it's always been a very, very shattering experience. A lot of times people don't even know how to talk about it. So it usually doesn't get addressed at all. So I really wanted to learn more about how we can sort of see the signs of somebody who's thinking about suicide and how we can sort of, gear them towards the proper resources. Well,
Thank you for sharing and thanks for your introduction. For those who just joined, I'll just ask you to introduce yourself and what we're hoping to get, since we're a small group, which I really appreciate. Eston Brown, if you want to just unmute yourself and introduce yourself and perhaps tell us what you're hoping you might get during this meeting, if you can. Can you unmute yourself, Eston? Thank you. Go ahead. We don't hear you, Eston. I'm not quite sure. If not, let's go to Anthony. Maybe, Eston, you can join in a moment. Anthony, could you unmute yourself and just introduce yourself and tell us what
good
you're hoping
afternoon. My name is Anthony McFarlane. I am living in America now, but I'm from the Caribbean, the island of St. Lucia. I have a first degree in theology, so I worked as a pastor with churches back home. And I'm now here in America. I've been living in America for 26 years. I graduated with my master's in rehabilitation counseling. I've worked with people who are both severely ill with mental illness or those who are just struggling. I've worked with youth. Recently, I was working with a place down here in Florida where most of the people that I treated were teenagers and young adults who were struggling with mental health. But due to the fact that the parents do not understand much about it, because in the Black community, we seem to take it as a behavior issue than to understand that it is an illness like high blood pressure, cholesterol, or diabetes. So I find myself explaining to people most of the time that it is an illness and we need to be more open about it. And we have a lot of young people who are considering suicide or attempted suicide because people do not understand what they're dealing with. especially in our churches. Most people in churches feel that it is demon possession, especially those from the Caribbean. They see it as a problem, that it's a sin problem and not as an illness. So I would like to learn more so I can share with my people and my community, because I cannot deal with my family members who have it because of the code of ethics that I follow. I cannot be able to provide counseling to my family, but I can provide it to someone else in the community, and somebody else will be able to provide it to my family members.
Thank you, Anthony. Florencia, are you able to unmute yourself and introduce yourself to us if you can? And just tell us what you're hoping we can accomplish, since we're an intimate group during this period.
Good afternoon. Good afternoon, everyone. I am with the community board, and I am a member of the Brookdale's CAB as well. And in the past, I've had to call 911 for folks who have actually taken pills or, whatever it is that they did, just keep them on the phone. And over the years, I have talked folks through that have had suicide ideations. However, I'm a Christian, I've been a teacher, and I've been a counselor. And the thing, though, is how do we, and I agree with what both persons spoke before, that they've already said some of the things. Where do we refer folks to who are really struggling but need to speak to someone? And how do we get rid of the stigma so that, folks will really seek help? As the gentleman said, if you have hypertension or anything else, you go to the doctor, and that to see it as such, and not to be labeled or, ostracized in any way. And so those, just how to really help someone who's struggling, because it's not always easy. I know for me, I pray, and I pray while speaking to, and fortunately for everyone that I've spoken to, they're now on a better path. So
Thank you for sharing. So let me try to share my slides. Let's see if I can. Okay. And let's see. Can everyone see this?
Yes.
Great, thank you. Okay, so really during the next half hour, I'm going to talk about depression in youth, which is really the way we try to prevent suicide. And I just want to say a few words about Project Teach, since I'm here today really representing Project Teach. And I want to tell you all about Project Teach because it's something that is near and dear to my heart and something I'm very proud of. So about 16 or 17 years ago, 2009, already 17 years ago, I was approached by a variety of people saying, how are we going to meet the unmet need of youth mental health in the state of New York? And I said, well, I don't know, because between stigma, shame, and lack of access, it's a challenge. And so we put forth a proposal, which is now a program that's been expanded its 17th year, where we provide free access to telephone consultation for all the primary care providers in the state of New York, pediatricians, family physicians, nurse practitioners, clinicians of all disciplines, where they can call up Monday through Friday, 9 a.m. to 5 p.m. to get information and guidance on how to care for these kids. So today we're going to talk about what we know about depression and suicide prevention, but I want all of you to understand that Project Teach is available to support all the primary care physicians and providers in the state of New York, and with a free telephone line for consultation and guidance. So at the end of this hour, I hope that you'll have a better sense of the understanding of the United States Preventive Services Task Force recommended annual screening for adolescent depression, review the guidelines for adolescent depression for primary care, meaning pediatricians, family physicians, nurse practitioners, to assess and manage adolescent depression, and also to understand the use of active monitoring to prevent and manage adolescent depression. So think about youth. What percentage of patients do you think have in the pediatric population have depression? Well, I think it's important for us to understand that for children under the age of 12, it's about 1 to 2%. Now, that may not seem like a lot, but that's a lot of kids. 1 or 2 out of 100. Now, for adolescents, it's about 8%, but it's more common in girls than boys. But by the end of adolescence, by the age of 18, it could be as many as 1 in 5 youth have gone through a depressive episode. So it's really prevalent. And less serious, but also concerning, is dysthymia or persistent depression. This is chronic low-level depression that doesn't meet the criteria of a major depressive disorder, but still represents a depressed youth. And then another 5 to 10% of youth have subsyndromal symptoms of depression. They don't meet the full criteria, but I would still view them as depressed youth. So by the age of 18, it's almost 1 in 4 youth have met criteria for depression, either major depression, dysthymia, or have subsyndromal depressive symptoms. That's a lot of kids, a lot of young people. And what are the different DSM-5 criteria? Disorders. It's major depression, which is the most serious, and that's having a persistently depressed mood with hopelessness, helplessness, difficulty sleeping and eating that's going on for at least 2 weeks with interference in functioning. Persistent depressive disorder or dysthymia, which is really chronic low-level depression. And then for many young women, premenstrual dysphoria, which for about 5 or 6 days before they have their menses, they become exceedingly depressed or irritable. We know that a certain number of youth who use substances have substance-induced depressive disorders. And then for other kids with chronic medical problems, they may become depressed secondary to another medical condition, whether it's diabetes or hypothyroidism or other medical conditions. Now, if you look at adolescents, you cannot tell whether they're happy, excited, depressed, manic, or suicidal by looking at them. Their appearance could be the same. You really have to ask them how they feel. And for many adolescents, when you ask them how they feel, they go, whatever. So oftentimes you really need to develop a relationship and rapport in order to really be able to understand what's going on with youth. So there has been the development of something called the Guidelines for Adolescent Depression in Primary Care, or the GLAD-PC guidelines. And this is something that all pediatricians and family physicians in the state of New York are familiar with, but it's available to pediatricians and primary care around the world. And I know that my Project Teach website, which is funded by the New York State Office of Mental Health now for the past 17 years, has hits from 70 countries and all 50 states. So although it's funded for primary care in the state of New York, we know because it's the free open access website, there's both education and screening tools available to primary care around the world. So the GLAD-PC guidelines really talk about the importance of annual screening for depression at the annual physical exam for every youth, 12 to 18. And there's a variety of algorithms. These are complicated slides, so I'm not going to bother going through them because at this point, they're just in the GLAD-PC guidelines, but it walks you through what to do, whether or not the adolescent meets criteria for major depression, whether they have suicidal thoughts or not, when do you refer to a psychiatrist? All of those algorithms are in the GLAD-PC guidelines. And they recommend annual screening at the annual visit for all youth. And this is something which is very important because you can ask kids, how do you feel? And they're likely to say, I'm fine. But if you give them a screening instrument, they're more likely to answer them more honestly. And that's oftentimes how we pick up symptoms of depression. So the screening protocol is really to give kids an annual screening instrument. And that's something that should be implemented in all pediatric and family medicine practices throughout the state, actually throughout the country. So what are the depression screens that we recommend? And all of you, whether you're primary clinicians or your clergy or your community active members or administrators, you should be familiar with this. So the one that's really highly recommended is the Columbia Depression Scale, and it asks a series of 22 questions that are 0 to 1. And there's a very important area to monitor these questions. There's also a much simpler instrument called the PHQ-9, modified for teens, and anything in the gray area is of clinical concern. So when they answer anything with an answer of 2 or 3 on the right side of the screen, those are usually concerning. And this instrument is recommended to be given at least annually to every youth 12 to 18 in New York State. This is a snapshot of our website, the Project Teach New York website. And these are all the screening instruments that are in the public domain that can be used. Right now, we have both in English and Spanish. In the future, I hope we'll have more languages. And these are all free. They're available. You don't need to print them. Just go to our Project Teach website. And as I said, they're accessed by 70 countries and 50 states in the United States. Here's just a case to give us an idea of what to do. Danielle's mother books a sick visit and says Danielle doesn't seem quite right. You've known her all her life as her pediatrician, and there have never been any concerns. She's now 15, and when you come into the exam, Danielle appears angry at her mom. Her mom says Danielle has quit basketball and is angry at her parents. Danielle appears irritable, and irritability in adolescence is the hallmark of depression. Many adolescents will say, I'm not depressed, but their parents will say, but they sure are irritable. And so it's important to recognize that irritability is really a hallmark of depression for youth. With the mother in the room, Danielle says that basketball was boring, even though she had been a good player. She says she's happy playing video games and watching Stranger Things. She says her parents annoy her. Her mom says Danielle grades have dropped, and she stays up in her room late, and she no longer hangs out with her friends. We go to the GLAD PC guidelines, which we're not going to go through today, and we recognize that does she meet criteria for major depression? She's been both depressed and she's lost interest, and she's not doing well in school. And so recognize that there are different mnemonics for depression. We recognize that with depression, sleep disturbances as well as appetite changes can also be the hallmark. That can be sleeping less, eating less or eating more, weight loss or weight gain. And so we look at this mnemonic as SIGI CAPS, is an interest or anhedonia, which is the loss of interest, guilt or feeling worthless, decreased energy, difficulty concentrating, changes in appetite and weight, psychomotor agitation, just slowing down, and then, of course, suicidal ideation. Symptoms that are most common in adolescents who are depressed is irritability instead of sadness. So if you say, have you been sad or depressed? They'll go, no, leave me alone. And that irritability is often the hallmark of depression. And they might say, but I have headaches, my back hurts, my belly hurts, and they're often anxious, and their behavior is deteriorated. So adolescents who are depressed often don't declare themselves as depressed, but they can be more irritable and have physical symptoms. The other thing is that about 1/3 of kids who are depressed also have more anxiety, more oppositional defiance, and often precedes the onset of substance use. Many kids who go on to develop substance use disorders had pre-existing depression that went untreated. So what are some of the risk factors and what are some of the protective factors for us to be mindful of? the unfolding of our genes. We know that if there's a family history of mood disorder, bipolar disorder, that puts kids at increased risk just genetically. If there are recent stressors, whether it's a death in the family, a history of trauma, conflict, divorce, or coexisting substance use, anxiety, ADHD, or eating disorders, those put kids at higher risk for depression. Some of the protective factors are having good parent connection to their school community, really a good social support, and I would add to that support with their church and their clergy, activities with sports, and good intelligence. But we know that so many of our youth have so many risk factors. We hope that they have some of these protective factors, but not all do. Genetic loading is the single most predictive factor because depression is highly heritable. 50% is really heritability, and really when you know about a family history of depression, you really have to increase your screening because of that high risk. So you want to meet with the parents, with the patient, with the parent, and with the patient alone. And you want to ask more questions. How long is it going on? How does it interfere with your functioning? And then determine what other exams you need to do. How has it impaired their functioning? Are they missing class? Are their grades dropping? Are they still on their sports or activities? Have they continued with friends or not? Do they have a social life? And you want to look out carefully for protective factors in the community. Do they have a relationship with family, to their school, to their community, to their sports? And then you want to ask directly about, have you had thoughts that maybe you'd be better off not living? Unfortunately, I recently spoke to an adolescent who said, I've been preoccupied with the fact that there's no purpose to life, and I can't stop thinking about it. I think it'd be better off if I were dead. I go, well, do you think you have any reason to have a life worth living? How do you think your family would be? Oh, they'd be sad. How would your siblings be? How would your friends be? Oh, they'd be upset, but they'd get over it. And so you really want to begin to challenge and question and say, you say that, but you're only talking about this because you're depressed right now. What you're experiencing is highly treatable and something that I recommend you seek treatment for. I often will ask parents directly about statements that kids have made, that things like, it'd be better off if I weren't living. And in the case of this adolescent who was 15, Danielle was alone in her room a lot. She was upset that her coach benched her and she felt disrespected. She denied drug use. She was tired all the time, staying up late at night, but she said suicidal thinking is stupid. She says nobody would care if she wasn't around. On her PHQ-9, you could see that she had several items in the 2 or 3 range, giving her a score of 15, but feeling down or depressed more than half the time, trouble falling asleep or staying asleep nearly every day, feeling bad about herself, trouble concentrating on things more than half the time. So here Danielle met criteria for major depressive disorder with a score of 15. But she wasn't directly suicidal. So what do we do? Is this mild? Is it moderate or severe? Well, she doesn't have suicidal ideation that she reports, no suicidal behavior, so it's not severe. We establish a safety plan. She says hurting herself is stupid. And we talk to the family about the importance for getting treatment for depression. Unfortunately, because of stigma and bias, so many families will say, she can go into counseling, but I don't want her to take any medication. But all of the studies demonstrate that if you meet criteria for depression, the most effective treatment is a combination of cognitive behavioral therapy and medication. So how do we decide, is this mild, moderate, or severe? Well, partly your impression from interviewing, partly the score on the rating scales, looking at the degree of impairment and understanding what safety concerns were expressed. So in Danielle's case, we didn't think it was severe, but we did screen for suicide. She denied it. She promised not to harm herself. We discussed with her a safety plan with her and her family, that if she felt ever that she wanted to hurt herself, that she would let someone know, and she would call 911. And there are very good suicide screening tools that can be utilized, and we hope that more and more primary care people are actually utilizing them in the community. We spend time working with families explaining that depression is a very prevalent and treatable condition, and one of the most important things that primary care physicians and healthcare providers can do currently is to educate families about depression. As was mentioned in the plenary, because of bias and stigma, there's a great deal of difficulty talking openly and honestly about mental health. And we refer families to the National Alliance of Mentally Ill, or NAMI, for the Family Guide. And we talk about the importance of screening in primary care with the APC toolkit. What are some of the things that we can do in terms of education? Well, we can talk about the importance of kids having good activities, keeping them exercising well, eating well, having spiritual and other community supports, get adequate sleep, limit the screen time and social media time, which we know for today is such a serious concern for youth, and develop a treatment plan. So we think that if this is mild depression, we can consider a period of active support. We could meet with her weekly in primary care and see how she does. Excuse me. If it were moderate, we would talk about starting a serotonin reuptake inhibitor such as fluoxetine or sertraline, and an evidence-based psychotherapy like cognitive behavioral therapy. If it's more severe, we would recommend initiating both at the same time. And if there was a concern about safety, perhaps referring to a higher level of care. So we want to really do active monitoring. So for many clinicians in the community, active monitoring is saying to your primary care physician, I'll see you instead of once a year, I'd like to see you once a week or maybe twice a month for the next few months to monitor how you're doing. Perhaps the depression will subside, and if not, then we could talk about implementing cognitive behavioral therapy or referring for medication. If it's more severe, then we talk about referring the family, when to refer to a mental health clinic, or when this should be continued in primary care. More and more primary care providers in New York State have been trained by Project Teach over the last 17 years. We provide intensive training for primary care. We've trained about 5,000 of the 9,000 primary care providers in the state of New York to really feel comfortable evaluating and treating anxiety, depression, ADHD, and aggression. If an evidence-based psychotherapy is needed, then work with the community to find the appropriate place. In every community, there are adequate resources. And if not today, with online therapy, most places can access this treatment. But we ask the primary care docs to call Project Teach, and we will, with our referral and linkage line, make a linkage so that the primary care doc can connect each patient, regardless of ability to pay, to the appropriate cognitive behavioral therapy. And cognitive behavioral therapy really gets kids actively involved in their care. It teaches them stress management skills like deep breathing or listening to music when they're stressed. It helps them to challenge some of their maladaptive thinking, and it keeps them active and busy when they otherwise were secluded and isolated in their rooms. And the TAD study, or the treatment of adolescent depression, really showed that the combination of cognitive behavioral therapy and fluoxetine was the most effective combination. You could get remission within 6 weeks with over 70% of depressed kids when you combined cognitive behavioral therapy with fluoxetine. And really the question for many people is, when is medication useful? And it really depends on the severity of illness, family preference, and remember that you want to know if there are safety concerns. These are the medications that are FDA approved for youth from age 8 and older. But we also recognize that it's important to know that if a family member has had depression, what medication was used, because based on pharmacogenomics, it's likely that if someone in the family responded to a medication, their first-degree family members might as well. So we start with the first-line medication. We start a low dose. We titrate it upwards, and then we keep it for about 2 to 4 weeks and see how they're doing. In some cases, you have to wait a full 4 to 6 weeks to get the full response. And each of these medications, whether it's fluoxetine, which is Prozac, escitalopram, which is Lexapro, or sertraline, which is Zoloft, we start at low doses and titrate them up, and then usually wait 4 to 6 weeks to see the good effect. What can get wrong with side effects? Well, generally they're well tolerated, but like any medication, anything can cause anything. So you could have some GI side effects. There could be sexual dysfunction. Some kids, as they get activated, might say, I'm having more suicidal thoughts, in which case it often requires stopping the medication. But in my own clinical experience, that's a very rare event. So some kids really get activated, and you want to be cautious because they could be that they're biologically predisposed to bipolar disorder. And if they become excessively activated, they could become hypomanic. So you really want to monitor these kids closely. There is a boxed warning for these medicines that says that if there's the emergence of either suicidal thoughts or excessive hypomania, that they should be reported immediately to the physician so that the medication can be stopped. The data for the boxed warning is rather weak. And actually, when the boxed warning came out, it made many primary care physicians reluctant to prescribe medicine. And in the year following the boxed warning, there was an increased rate of suicide in the United States. So untreated depression is much more serious than the possibility of emerging suicidal thoughts. In none of the cases that were emerging with suicidal thoughts was there any completed suicide. So the current thinking is these medications are safe and effective and should be monitored carefully. So what are the take-home points? These medicines are safe and effective. If the increased risk of suicide is untreated depression, not treating depression. So in summary, the management of depression in kids is important because it's a common, identifiable, and very treatable disorder. Psychotherapy is acceptable as a first line for mild to moderate depression. But if it's moderate to severe, you really have to do medication plus cognitive behavioral therapy. And the TAD study, or the Treatment of Adolescent Depression study, showed that if you combine the two treatments, you get a 70% remission within 6 weeks. Depression can be managed in primary care. So the concern right now is there never will be enough child psychiatrists to take care of all the depressed youth. However, more and more primary care physicians and nurse practitioners are now comfortable and educated to take care of depression in primary care. And they really are the first line for care because families have a relationship with them, they trust them, and they know the families. There is a guideline for parents about medication that's put out by the American Academy of Child Psychiatry that's available free online. And we have a little time for questions. So I'm going to stop sharing and see with the people here if we have opportunity, if people are willing to turn on their video and unmute yourself, we can have time for a little discussion.
Thank you, Dr. Fenari. Does anyone have any questions or comments? I have a question. I'll start off, Dr. Fenari. Thank you so much. Really, I learned quite a lot from your presentation. What I was wondering about in the context of this particular summit today is, did you find racial disparities in suicide, the risk for suicide in the teen population?
It's a wonderful question. So Let me begin by saying that I had the privilege of doing a medical mission to Guyana 3 years ago. And the purpose of that medical mission was to try to teach pediatricians and family physicians in Guyana much of what I reviewed today, but do it in a more intense way so that they could develop competencies. And what I learned that in many communities, not just Guyana, child protection laws are not implemented. I was there, I was in their mental health clinic, and a grandmother came in with her 12-year-old granddaughter and said, my daughter's boyfriend is sexually abusing my granddaughter, and I want her to have a therapist so she can learn to cope with this. He's a very nice man and he's a good provider. So I looked at the pediatrician. I said, don't we have to report this? And they looked at me and said, didn't you hear what the grandmother said? He's a nice man and a good provider. So part of the challenge is there remains in many communities, despite child protection laws, a serious deficit in implementing protecting kids. And so many kids who are not protected go on to be depressed and suicidal because they feel it's hopeless. And I've had cases where when the child discloses the sexual abuse, the mother slaps them and say, you know, don't lie about your stepfather or your father that way. So part of the challenge is really trying to work with the community to educate the importance of child protection. And that's also true for domestic violence, because domestic violence is a form of child abuse for a child. When a child witnesses and experiences the unpredictable domestic violence that generally their mother experiences at the hands of either their father or another perpetrator, that hopelessness is profound. So it's not so simple as to worry about identifying and treating depression with cognitive behavioral therapy and medicine alone. It's also the importance of recognizing the importance of identifying and protecting kids from physical abuse, sexual abuse, and domestic violence experiences, and recognizing that those experiences put youth at higher risk for suicide. The other thing that I learned in Guyana, and probably in other areas of the world as well, until very recently, suicide attempts were against the law. And it was a remnant of colonialism. So if you talk about racial disparities, it's a function that in colonial days, many people were the property of their master. If they tried to hurt themselves and they survived, they went to prison. They didn't go to a hospital. And so many people, when they were feeling suicidal, had to find a way that would be successful. And Guyana had the second highest suicide completed rate in the world. Oftentimes, because it's below sea level, people were ingesting insecticide that was available the way sand or ice melt might be available on the streets of New York during the winter. Vats of pesticide were openly available in the streets of Georgetown, Guyana, because the streets are below sea level and often are flooded. So there's a large mosquito concern. So part of the challenge is recently now suicide is viewed as a public health problem, not breaking the law. A concern about the importance of securing the pesticide so it's not so readily accessible, developing programs that will assess depression and suicide and really protect kids and women from domestic violence. And I think that's true, not just in Guyana, but I think that's true in many nations, certainly many Caribbean nations, but it's also true here. Because remember, when people come to the United States from their country of origin, they bring with them many of their cultural attitudes and beliefs that they had growing up. And so I can't tell you how many families the kids were told to accommodate to the sexual abuse because he's an otherwise good provider. And of course, we know that unless we can figure out a way to truly protect kids and women from both physical, sexual abuse and domestic violence, we're putting kids at increased risk for suicide and depression.
Thank you. Florencia has her hand up, and we were given a notice that we have about 6 minutes left for this session.
Okay, Florencia, please go ahead.
Hi, I just wanted to quickly ask, do you find that there are youths here that will self-medicate either alcohol or marijuana instead of seeking medical or
Yeah,
mental?
so there's no doubt. Earlier, one of my slides said many kids, if they go on with untreated depression, will then lead to substance use disorders with alcohol, cannabis, and other substances as a way to kind of numb themselves. And if you go to the substance use programs for teens, many of these kids, when you screen them, they're depressed, but they said, by using cannabis or alcohol, they could cope with the pain of their depression. So there's no question that for many youth, that form of self-medication was a way to cope. And of course, you want to keep them sober. And today, because we're cannabis nation, cannabis is everywhere, right? And alcohol is so readily available. You just have to walk down the street and we smell it everywhere now, right? Because there's a dispensary on every corner. And I'm not opposed to that in the sense that I'd rather see that than have people buy things from drug dealers and you never know what you're getting. On the other hand, kids have vulnerable brains. And what happens after the age of 26, when the brain is fully mature, if adults want to, use alcohol or cannabis in a safe way that doesn't lead to increased risks of behaviors or motor vehicle accidents, that's their business, right? And I think we do know that so many youth are self-medicating with alcohol, cannabis, and other substances as a way to numb themselves from the pain of their depression and their trauma.
Thank you.
I think clergy and school teachers are in the prime position because you spend more time with kids than the healthcare providers do.
That's true. Thanks, Dr. Ferrari.
Does anyone else have any questions? We only have 5 minutes left now. Questions or comments?
While we're waiting, I'll share with you an experience. I took a group of physicians from my office yesterday to see a show on Broadway called All Beautiful Things. I don't know if any of you have heard about this show. Anybody hear about it?
Heard about it, but not familiar.
I'll tell you
Yes.
about it. It's a one-person show, and it's about a little girl who, from the time she's 7, has to learn to cope with the fact that her mom has depression and multiple suicide attempts. And the way she learns to cope is by making lists of all the things that she's grateful for. And by the time she's like 10 years old, she's got 100 things she's grateful for. She's grateful for ice cream. She's grateful for going to the movies. She's grateful for a puppy. She's grateful for all kinds of things. And by the time she's an adult, she's got 1,000 things she's grateful for. But all of that gratitude was the way she could cope with the fact that she was living in an environment where she really had an emotional neglect because her mom was chronically depressed and suicidal, and she didn't know what else to do. And she did have a trusted school teacher who was helpful, which is very important. But I think that for our youth today, we really want them to learn to appreciate what they do have and be grateful for that. And I think in so many ways, whether through sports or through religious activities, that kind of a spiritual framework to allow for gratitude. Because yes, everyone is faced with challenges, but we also have to recognize that we have to be grateful for what we have. And these are really challenging times in our country and around the world. And youth are really facing all kinds of unprecedented challenges. But I think the show yesterday was very powerful because it demonstrated this little girl who grew up and in spite of the challenges she had at home, by keeping track of every beautiful thing that she could be grateful for, by making lists, it allowed her to cope by saying, look what all I have. And I thought it was very powerful, very meaningful, and I think it's something that we could think about and pass forward as we talk to youth and families.
Anybody have any questions? I think we're gonna get.
Thanks for that.
Thank you, everyone. Have a wonderful day, and thank you for everything you do to support our youth.
Thank you, Doc.
Thank
Be
you
well.
for
Have a
sharing
wonderful
your
day.
expertise with us.
Thank you. Thank you for inviting me. Have a great day.
At this time, we want to thank sincerely all our presenters. And Stephanie O'Keefe that presented on domestic violence. Then we had Dr. Shadow that presented on cardiovascular. I saw that group was very, very engaged. And Dr. Victor Fanari, who presented on suicide prevention. Prostate cancer was by Mr. Diop. And then we had the colon cancer by Dr. Dominique. I trust that all the information that you received today would just motivate you to do more, not in your immediate circle, but also to expand that circle. I really appreciate our keynote speaker as well, Dr. Scott, giving us our individual responsibility, what we can do in our network, as well as extending it out to the community. At this time, the evaluation would be launched, and we are asking everyone please to fill out the evaluation for us, because in this way, we will know how to better serve you the next time around. Usually, we do the Caribbean Health Summit every 2 years. There was a time when we were doing it in person and every year, but since the pandemic, we have gone to every 2 years. So I think the evaluation is in the chat. Did you all see the evaluation?
Chat?
Yes,
Yes.
it's in the chat. I'm posting it. It's posted twice already.
Okay. So I can see it. The link is in the chat. You just click on it and
Yes.
complete it for
Yes.
us.
Yes.
And while we are completing that, I'm glad Dr. Scott stayed on. So One Brooklyn Health has been our partner from the very inception. At the time, it was Kingsbrook Jewish. But now it has expanded to One Brooklyn Health. So now that we have been able to talk about all these issues, Dr. Scott, can you share with us what more we can do as a collective? I know you did mention some of it, but as a starting point, where do you see us starting so that we can make the most impact in the community?
So I really think one of the major challenges that we deal with in the healthcare industry is health literacy. There's a lot of fear, an awful lot of fear, and I understand that. I understand the fear of entering the healthcare system. It's difficult to navigate. Sometimes getting an appointment can be challenging. Once you get the appointment, it leads to another appointment, and test and blood test and radiology test. So I think you said every 2 years, I really think that this kind of collaboration between health systems and the community is much needed, especially during this time when people have lost even more access to healthcare. I think topics about how to navigate the healthcare system would be a good topic. I think including some of our community-based healthcare organizations and other community-based organizations that do home health work, that do navigation work. So I am going to advocate that we create a forum like this together more often. There are a number of community health centers that I think would be really good to introduce them in forums like these. And of course, we have access to being able to push out invitations to the patients that we serve. This has been wonderful. I actually stayed and listened to the cardiovascular presentation and learned something myself. And so That's what I would advocate for. I think once every 2 years is not enough. Healthcare is under attack, and there's a lot of misinformation, both about the role of healthcare institutions, but also about medications, right? I'm sure people have a lot of questions about obesity and obesity management, right? So you have the option of getting procedures, you have the options of taking medications now that promote weight loss. People are still doing plastic surgery. Right, so something like that, obesity still has a lot of stigma attached to it. And I'm just thinking, even if we took time, maybe this was 4 to 6, maybe an hour and a half, we could have more frequent conversations like this, right, where we dive into maybe one or two specific topics. But I think that would be a big help to the community. I think it would help to kind of bridge the gap between those of us who provide health services and those who receive them. If we could think of a way to reach populations that maybe would struggle with getting on Zoom. In person is more of a logistical challenge, but there might be a way that in community spaces, we could set up access to be able to join this type of electronic forum. So those are some of my ideas. One Brooklyn Health is here for you and for the community, and we've had some incredible speakers here today, but we certainly can tap into our workforce in addition to some of the other organizations that we collaborate with, and I'm confident that we would be able to stimulate really good conversation at the right level for our communities.
Thank you very much. We appreciate that. I would also like to call on Dr. Victor Fanari that spoke on suicide prevention. Dr. Fanari, are you still here? What would you suggest as a next step for us?
Thank you, Janice. First of all, I want to compliment everyone for this presentation today and the importance of really the conversations and really continuing these conversations. So it's terrific. I think the first thing we have to do is recognize that our youth are struggling and not think it's about them, but it's about all of us. These problems are so prevalent, it touches every family. And I think that because of that, we really have to recognize that we have to talk openly about it without shame, without fear, without worry about stigma, because the conversation allows other people to feel more comfortable continuing the conversation, as Dr. Scott said, for every medical problem, but certainly for depression, anxiety, suicidal thoughts. These are very prevalent problems. I reviewed in my group, almost 1 in 5 youth will meet criteria for depression by the age of 18. These are very prevalent. And for some youth, that leads to suicide. And suicide is the second leading cause of youth, age 15 to 24 in our country. And that's something that should be treatable, should be beatable. And it's really upon us to treat it, to talk about it, to face it, and to address it. And I know so many families are reluctant to get mental health care. However, mental health is physical health. Our brain is a part of the body. And the truth is that we really should be talking more openly about our own concerns and our own families to help people recognize that it's something that they can talk about openly, without shame, without fear, and with really the same way you would talk about any other health problem. And so I compliment you for this conversation, and I hope in the future we'll talk more about mental health, because the truth is we have no idea the impact of AI, social media on our youth, and it's a rapidly changing landscape. And youth are growing up today, have a huge, huge generational shift. And it's hard for us to recognize it because many of us didn't grow up with computers and with email and text and social media and now AI. So we have to really understand what's the impact on our developing youth when they're growing up in a world that's so different than we understood growing up ourselves. So stay tuned. That's a future conversation.
Thank you so much, Dr. Fanari. Really appreciated that input there. Stephanie from Safe Horizon presented on domestic violence, and we know how prevalent that is in our society. So, Stephanie, I will ask you to give us, what are your thoughts about next steps? What can we do?
Thank you. And thank you. This has been such an informative event. Thank you for inviting Safe Horizon to be part of it. Something we talked about was keeping the conversation going. I mentioned that I think this is a big theme in a lot of what was talked about today, but with domestic violence especially, it's something that thrives when it remains unseen. And so the more we open up and talk and recognize that there's very subtle signs of domestic violence, you don't want to walk around thinking every relationship or your own is always going to be harmful, but you want to be aware that sometimes your gut is telling you something is off and you want to listen to it and just open up conversations. Hey, I saw your partner say something that was mean to you. Like, what did you feel when they said that to you? Just starting with open-ended questions and this way providing support and connecting people to what their options are. In an abusive relationship, you feel stuck, you're powerless. You're not powerless, but you feel powerless. And by connecting with other people, that's empowering, not being isolated and talking about it and just raising awareness.
Thank you, Stephanie. Do appreciate that. We will go to Dr. Dominique. Are you still here? Dr. Dominique's presented on colon cancer. Are you still here, Dr. Dominique? I do not see him here. And then we had Mr. Diop presenting on prostate cancer. I do not see him here as well. Claudia, are you here? Okay, Claudia is not. I don't see her here. But those are our partners from New York Presbyterian, Weill Cornell Medical. And there's lots of information that they shared. And I'm sure as we proceed in these kinds of forum, we would learn even more. One of the things I learned from my group that Weill Cornell Medical, they have a van that can come to various community-based organizations if advance notice is given to do lung cancer screening as well as some other screenings. So maybe some of us from community-based organization may want to engage them on that. When I send out my thank you note to everyone who attended, I will ensure that I have their contact information available. So if you would like them to come out to your facility, you can reach out to them. Do we have any last questions that people would like to ask?
Janice, can I say a word?
Sure, go right ahead.
I just wanted to remind everyone, for those who are aware and for those who aren't aware, educate folks, that New York State supports a program called Project Teach. Project Teach is funded by the New York State Office of Mental Health, and it's available to every provider in the state of New York with education and real-time telephonic consultation with mental health providers for youth mental health and maternal mental health. It's a very large perinatal program because perinatal concerns are a serious issue with maternal depression. And I think that everyone should be aware that this is available. You can go online and look at Project Teach NY. There are resources, there are screening instruments, there's all kinds of educational activities. And we're hoping that people become more and more aware. We're in our 17th year. It's hard to believe there's 9,000 primary care providers in the state of New York, and we've had contact with at least 5,000 over the last 17 years, and we're hoping to do more. But I just want to say that it's so important because maternal mental health is such a big concern impacting youth mental health. So parents realize that their own physical and mental health is important in order for them to care for their families. And maternal mental health is a very serious public health concern. And I just want people to know that Project Teach is available to everyone free of charge, funded by taxpayer dollar by the New York State Office of Mental Health. And it provides education. We'll come to your practices. You can call us up Monday through Friday, 9 to 5, with questions about cases. You can have screening instruments. And we hope people will take advantage of that.
Thank you very much, Dr. Fanari. I noticed someone is asking in the chat if the recording would be available. We would, as soon as the recording is available, we will first of all make it available to all our partner organization. It will be on the APC's website as well, so you can access it at that time. I think in about a week, in about a week's time, that should be available. Okay. I want to also take a moment to thank all the members of the planning committee. Sharon Devonish, lead from One Brooklyn Health System. Then we had Adele Flateau from the National Association for University Women. Then we had Claudia Duarte, and she is from, let's see here, Weill Cornell Medical, New York Presbyterian. And then from APC, we had Hildegard Reimers, who is our Secretary Treasurer, and also Dr. Peters, Yvonne Peters, who is our board chair, and our Vice President, Dr. Naomi Modest. So thanks for the labor of love that you have done in helping us to put this together. And just as we started on time, we are finishing on time. Please remember, everyone, to complete your evaluation, because this is the way we will be able to serve you better the next time around. And Dr. Scott, I'm going to take you up on that offer so that we can have more community forums to get really down to all the different things that we need to do. We need to bring it down to the basics so that we can have healthier communities. So again, ladies and gentlemen, I want to thank you all for being here and for participating. And I look forward to seeing you soon as we continue these various conversations. Take care, everyone. Be safe and be well.
Thank you.
Bye, everyone.
Bye, everyone.
Have a
Please
Bye-bye.
make sure you
Thank you.
complete your evaluation before you leave.
Consider it done.
Thank you very much.